Welcome, everyone. I'm Amanda Smith, co-chair for the Wellness Workshop Planning Committee. Thank you for joining us at our virtual wellness workshop and for logging into the Zoom webinar. This is how we'll capture your attendance. You can use the chat feature to raise your, you can use the chat feature or raise your hand to ask questions. Also, please share in the chat box your name, title, and organization you're here with. As more people are rolling in, I'll welcome you again. I'm Amanda Smith, co-chair for the Wellness Workshop Planning Committee. Thank you for joining us at our virtual wellness workshop and for logging into the Zoom webinar. This is how we'll capture your attendance. You can use the chat feature or raise your hand to ask questions. Please be aware that the session will be recorded and made available through our website and social media links to inform and educate the public of this topic. Therefore, keep in mind, if you choose to participate in an identifiable way, you acknowledge that your name and/or video will be recorded, and you are authorizing the use of your information in the recording as described. You have no obligation to speak in the recording. A recording of today's workshop is protected by copyright law and is not to be copied. So once again, I'm Amanda Smith, co-chair for the Wellness Workshop Planning Committee. The Wellness Workshops began 10 years ago to support mental health professionals and community members in Denton County that work with children, youth, and families. As the Wellness Workshops have grown, we have begun to support mental health professionals throughout all of North Texas and beyond. Cook Children's Center for Community Health launched the Thriving Communities Collaborative in 2023, which brought together community partners with the same goal of improving children's mental health or children's health in North Texas. The group focuses on mental health, caregiver support, healthy lifestyles, and asthma. For more information on the resources and education that is provided by the Center for Community Health, please visit our website using the QR code on the slide. We have many people to thank for working collaboratively to put this event together. We'd like to thank the members of the Wellness Workshop Planning Committee, Cook Children's for providing CEUs, and you, if you've attended our previous events, for providing feedback. We planned this program with you in mind. We'd also like to thank each of our speakers for giving their time and sharing their expertise with us today. With permission, we will post the slides and video from today's workshop on the Center for Community Health website for ongoing CEUs. As a reminder, you can find past webinars on the Center for Community Health website, and you're able to earn CEUs for some of those as well. We'll put the link for this in the chat. Also, if you did not receive the meeting packet with presenter slides, you can also find that link placed in the chat. Once on the website, you'll navigate to the Mental Health tab and then find today's presentation and click Download PDF. Perfect. Okay, so now for some housekeeping details. I'll be hosting the workshop today along with Lindsay Schaefer, the chair for the Mental Health Action Team. We invite you to engage with the speakers in the chat box or using the Q&A feature or by raising your virtual hand. You can talk with the group as a whole or one-on-one by clicking on the button next to the To field in the chat feature. This is located just above where you type your message. We'll have time for questions throughout the presentation. You can use the Q&A box to ask your question, or if you'd like to speak live, again, you can raise your virtual hand and we can unmute you to speak to us directly. So today we will be discussing disordered eating in youth and signs and symptoms of disordered eating versus eating disorders. Then we will discuss perceptions and stigma with eating disorders over time. You will learn interventions and other factors in treatment. We'll share a pre-recorded interview with Kristen Remedies, who is in recovery for an eating disorder, and you'll be able to hear from her mother live. And last, we will share resources and referral options with you. We do not have scheduled breaks during our time together, but we'll pause periodically to take questions. Feel free to take a break during this time or whenever you need. So by attending today's workshop, you will learn characteristics of disordered eating behaviors, understand current trends in youth displaying disordered eating, be able to summarize differences between disordered eating and eating disorders, and identify at least 2 evidence-based interventions to use with children and teens displaying disordered eating behaviors. An evaluation link for today's event will be shared at the end of the program. All are encouraged to complete the evaluation, and it is required to receive continuing education credit. So today's speakers have no conflicts of interest to report regarding today's presentation. All right, I am now pleased to introduce our speakers, Melissa Bloom and Samantha Hicks Peterson. Melissa obtained her master's degree in nutrition at Texas Women's University and completed her dietetic internship there. She then started her professional career in bariatric surgery and nutrition in the media until she moved into eating disorders in the inpatient and residential setting. As a result, she was recruited to build and direct nutrition treatment at various outpatient settings. Her passion for outpatient treatment of eating disorders and disordered eating grew, and she has stayed in this type of setting since, founding Empowered Nutrition. Her expertise is in working with anorexia, bulimia, binge eating disorder, avoidant restricted food intake disorder, and disordered relationships with food that may not involve an eating disorder diagnosis. Sam is a licensed clinical professional counselor, certified alcohol and drug counselor, and certified eating disorder specialist and approved consultant. Sam has been in the field of mental health for over 10 years. She currently works with Monty and has for the last 4.5 years. Sam began her time there as the clinical director and has since moved into the role of regional director of the Central and Southeast, overseeing the programs in Illinois, St. Louis, Houston, Atlanta, and Miami for adults and adolescents in residential, PHP, and IOP settings. Throughout her career, she has worked all levels of care with clients who struggle with primary eating disorder, substance use, and other mental health conditions. Sam is EMDR trained and is passionate about helping individuals and their families live meaningful lives. So thank you for joining us today.
Okay, take it, Sam.
Awesome. So we're going to start with just an overview of eating disorders, some diagnostic criteria, when we should be concerned, and some prevalence data. So the difference between disordered eating and eating disorders are serious mental health illnesses in which our clients become highly distressed by the beliefs that they have. The attitudes and behaviors that they're engaging in are really restricting their food intake, where this illness is impacting many facets of their life and impacting their daily functioning. It has the second highest mortality rate of any mental illness that people can struggle with, where disordered eating is where behaviors and beliefs surrounding food and exercise can negatively impact a person's health, but are also often less severe or frequent in nature without compromising those daily functioning struggles. So some signs of disordered eating is being preoccupied with food, counting carbs, being very focused on what you're taking in, a fixation on body size, shape, and weight. Starting to withdraw from social activities, maybe an increase in irritability or fatigue, and starting to see some food rules where I can't have a brownie because I ate dessert yesterday, or certain thing you have to eat fruit at every meal or snack. These things can start as disordered eating and stay there, but occasionally they can also lead into developing an eating disorder as well. So the different types of eating disorders that we're going to describe and kind of talk through some of the diagnostic criteria for them is binge eating disorder, where you'll also see it written in here as BED, anorexia nervosa, and there's subtypes of restricting or binge and purge subtypes. There's bulimia nervosa, other specified feeding and eating disorders, or OSFED. avoidant restrictive food intake disorder or ARFID, and unspecified feeding and eating disorders. So the first one, being binge eating disorder, is characterized by recurrent episodes of binge eating that are associated with 3 or more of the following: eating more rapidly than normal, eating until feeling uncomfortably full, eating large amounts of food when not feeling physically hungry, eating alone because of being embarrassed by how much one is eating, and feeling disgusted with oneself, depressed, or very guilty about the overeating. This occurs at least 1 time a week for at least 3 months, and it is not associated with recurrent uses of inappropriate compensatory behaviors. A big thing here is this is a consistent pattern of overeating, not something like many of us are going to probably partake in with others in a couple weeks with Thanksgiving, but something that we're potentially doing alone or out of periods of restriction.
So, along with the diagnostic criteria, there are signs and symptoms of binge eating disorder and really what to look for and when to be concerned in kiddos that you have, whether they're your students or your own children. One of the top things we see working with this population is the disappearance of food or hoarding of food. A lot of times parents will say, I don't know where all of the bagels went last night. I don't know where all of the cereal went. And that doesn't necessarily mean automatically they have binge eating disorder. There could be a lot going on there, but that could also be a sign. Fad dieting, a lot of people don't realize that binge eating disorder truly is a restrictive eating disorder. It does start that way. So when we hear students, children, teens, adolescents talk about fad dieting, that is a warning sign and a symptom that really goes across all different types of eating disorders, but including binge eating, which most people wouldn't consider. Preoccupation with food, weight, body size, spending a lot of percentage of their brain energy on these topics throughout each day. For example, being on the notes section of your phone, recording certain things. That's a common symptom we see and sign we see in our adolescents and youth. Eating alone and avoiding social situations with food, feeling really a lot of guilt and levels of sadness just throughout their lives, but especially feeling guilt with food. Hey, I feel really guilty. They may not say that, but I feel really guilty after eating this donut, and I feel like I may need to compensate, or then that encourages a binge. Often we see fluctuation in weight, and GI issues also is standard across the board as well, and withdrawal from family and friends. Again, if someone is prioritizing the topics of food, body weight, and shape, then that leaves very little energy to expend on other important things in their life.
Anorexia nervosa is characterized by a restriction of energy intake relative to requirement. So this means based on their age, sex, developmental trajectory, and physical health, how much caloric need someone has. They are eating well underneath that. What someone is needing and their ideal body weight is not solely based on BMI, but now an expert, a dietitian, will identify based on their history what should their ideal range of weight be for them, and currently they're projecting much lower than that. There is an intense fear of gaining weight or becoming fat, which becomes a great preoccupation for the individual. And there is a disturbance in the way in which one perceives their weight or shape versus what we see. So they may see something very different when they look in the mirror compared to what we are seeing. And there's 2 subtypes that can be associated with anorexia. A restricting subtype is during the last 3 months, they have not regularly engaged in binge eating or purging. This means they're just reducing that overall energy intake that they have they're consuming within their day. The purge or binge purge subtype is that during the last 3 months, they've regularly engaged in binge eating and purging as well.
And when to be concerned about anorexia. And remember, when we talked about disordered eating versus eating disorders, a lot of these signs and symptoms are very much so present in disordered eating, but they're at a lower level and can progress to this. Often we see dramatic weight loss in patients with anorexia, not always, and that's a hot topic in our professional world, and we'll explain a little bit more about that later. We often see hiding body, and that basically means like wearing baggy clothing, putting blankets and pillows over areas that may be of concern, like the stomach or abdominal area. Um, Also preoccupation with food and body shape and size, eating alone, and avoiding social situations with food. There's a lot of pressure that someone with anorexia feels from the eating disorder to make certain decisions. And if you can imagine someone sitting there with a cheeseburger in front of them, someone with an eating disorder has hundreds of thoughts about that decision. What should they do? How will this affect me later on? How many calories are in this, et cetera, et cetera. Typically, we see a high need for achievement in this population. So, type A or perfectionism. Again, not always, but that's a commonality. Often irritability, and we can also label that as hangry. Intense desire for control. That's where therapy comes in, and how the eating disorder relates to that. GI issues, withdrawal from family and friends, and other physical symptoms that I'm actually going to show you here in just a second. So this is just a graphic that really brings home the point that anorexia and all eating disorders in reality can affect the entire body. It's not just about we're not eating enough. Oh, well, because in our society it's so normalized restriction of food. And so it really is an incredibly serious issue. Again, we'll explain a little bit more about that and statistics later on. But it affects everything from the brain to your toes, truly. So a lot of times people from anorexia will pass away from heart issues. Your body just cannot handle your heart beating and preparing that blood flow to have energy for the rest of your body functioning. Intestines, we can think of that. A lot of people say, yeah, they're not eating. So our intestinal microbacteria, microflora is just not where it needs to be. So constipation and bloating, it's less movement in the GI tract. You're utilizing peristalsis, the movement that you have through it, for digestion less, so it becomes less effective. Low iron, anemia, cannot think straight, dizziness, fainting, nail brittleness, hair thinness, essentially everything that malnutrition can bring. A lot of what we see in adolescence is a period or a menstrual cycle stopping or becoming abnormal. And that's due to hormonal fluctuations, not enough fat in the body or fat consumption, as well as just not enough energy to have something that's considered unnecessary for the body to live. It really, what's the word I'm looking for? Conserve the energy for other purposes, like your heart beating.
Then bulimia nervosa has similar characteristics to binge eating disorder, where there are recurrent episodes of that binge eating again, where they're more rapidly eating, eating beyond the point of feeling uncomfortably full, eating large amounts of food even when they're not physically hungry, eating when alone because of being embarrassed of how much they're eating, and feeling disgusted potentially after they're eating as well. This is then characterized differently than binge eating disorder because there are recurrent episodes after the binge of inappropriate compensatory behaviors in order to prevent the weight gain. So the purging subtype is what I think we typically think of with binge eating disorder or bulimia nervosa, where there's the self-induced vomiting, but the bulimia can be coupled with laxative use, over exercising, diuretics, any other medication, or fasting in between. So it doesn't just have to be that self-induced vomiting that I think we can typically think of when we think of bulimia nervosa. Again, this is happening at least one time a week for at least 3 months. And there is, again, a very big influence of what someone thinks about their body weight and shape with how they're engaging in food.
And some of the signs of and symptoms of bulimia are frequent bathroom breaks after meals, signs of smells of vomiting or vomit, medication remnants, um, avoidance of social eating situations, hoarding of food, again, like binge eating disorder with the compensatory mechanisms, excessive water intake. A lot of times, sometimes we see in our patients ideas, and we don't know where they get these ideas, but like excessive water consumption to then make it easier to purge, or vomit, self-induced vomit, and certain types of foods as well are a little bit more preferred for someone engaging in regular self-induced vomiting. We can see an exercise regimen that is quite rigid in bulimia nervosa. Calluses on the back of hands and knuckles. I typically would see some of this in higher level of care, not so much in lower level of care, but this is a big sign that someone is regularly engaging in self-induced vomiting, at least with their fingers and not necessarily another tool like a toothbrush, for example. Teeth discoloration or the enamel wearing away on teeth, like sensitive to cold and hot foods. A lot of times, dentists will be able to determine or detect, huh, this seems odd. This child has lost a lot of enamel on their teeth. They could be purging or self-induced vomiting. And so dentists a lot of the times can be the first point of contact of seeing a sign and symptom for someone with bulimia. We often have bloating, and that can be due to dehydration and constipation. And a lot of times people will also see swelling of parotid glands or salivary glands. And that really, there's swelling along the outskirts of the cheeks, and from irritation. And then withdrawal from family and friends. Again, that is consistent amongst all different types of eating disorders. And here's another graphic for how bulimia affects your body. I think the biggest one and the most scary sign and symptom for someone with bulimia could be esophageal tears or ruptures in your esophagus that could cause internal bleeding. That could happen for anyone. I know Sam and I have seen all different kinds of folks in eating disorders, and the bodies are never predictable. In a lot of cases, we have different symptoms for different folks at different levels and severities of eating disorders. A big one is also dehydration in folks with bulimia because of the vomiting, and the risk there. Irregular absent period. You notice that with anorexia, there was a weight loss component there. In bulimia, that's not necessarily all the time evident. In my experience as a dietitian, looking at body weights, there may not be as like seeing someone in that emaciation that happens. It may not happen with bulimia. There could be weight stability or even weight gain.
And avoidant restrictive food intake disorder, or ARFID. I feel like this is becoming a more widely recognized eating disorder. This is an eating or feeding disturbance as manifested by a failure to meet their appropriate nutritional needs associated by one or more of the following. We're seeing potentially significant weight loss or a failure to achieve expected weight gain or faltering growth in children, significant nutritional deficiencies, dependence on enteral feeding or oral nutrition supplements, such as Ensure or Boost, and a marked interference with psychosocial functioning. There is an absence compared to where we may see the similar characteristics of a restriction in their energy intake, similar to anorexia nervosa. What you will not see in a client who has ARFID is the focus on weight gain or shape. That is not what is driving this reduction in their energy intake. This disturbance is not caused by any medical condition. A lot of times an occupational therapist can be very helpful in supporting a client with this if there's something going on with their tongue or their swallowing abilities. But really this could be characterized by sensory characteristics of the food, where someone doesn't like the texture of something, and so they start restricting some of those categories of food. It could also be stemmed out of a fear of choking or throwing up, where someone will reduce their amount, what they're eating, because of that. This can also look a lot like picky eating, where we have kiddos who only eat in certain types of food. And so with this type of diagnosis, we're going to work on expanding some of those acceptable foods and safe foods that a client feels like they can eat safely.
With ARFID, a lot of the times, working with healthy body weights and what that looks like for each kiddo or each adult, we typically see drops in growth chart patterns, kind of like anorexia, not always with anorexia, but usually with ARFID, it's pretty typical to see someone go along a weight graph or a weight chart, BMI, height, weight for age, and then there's a dip or there's a leveling off where the growth just doesn't continue to occur. Sometimes there's been the failure to thrive diagnoses in young children with ARFID. And I, like Sam had said, I think the most common thing we hear from our ARFID patients and parents is that, hey, my doctor said that this will stop for my child eventually. Like, oh, they'll just get over picky eating. Oh, their palate will increase. And it just never does. So someone's coming in to us for 11, 12, 13 years old, and for 5 years they've been eating chicken nuggets and french fries only from Chick-fil-A type of thing. So we do see some dramatic weight loss, and again, not always, because eating disorders, weight is only a piece of eating disorder diagnosis and treatment. Limited range of preferred foods. So for example, picky eating does get worse or stays the same. I did have a client once who came to me only eating mac and cheese and candy, sour candy. That was it. And ended up expanding their foods to like 10 to 15 different entree options, which was huge for that kiddo. But it's truly just mac and cheese, one brand, with whole milk, for example. Um, Often providers, like I had said, will dismiss, like they'll grow out of it, which is great if your child does, but sometimes that's not the case. Like Sam said, if there's a like high anxiety or fear of choking or vomiting, um, increase in nervousness or anxiety when unsafe foods are present. And again, no, there's like usually kiddos with ARFID are like, yay, I gained weight today. I ate another food. So that's a lot different than what we see with anorexia. and GI issues along with malnutrition symptoms. So vitamin and mineral deficiencies, some of those signs and symptoms we did see with anorexia. It's just from malnutrition. So if someone's only eating mac and cheese, there's a big risk that they could be vitamin and mineral deficient or insufficient.
Then we have other specified feeding and eating disorders, or OSFED. This is, as we know, working with the DSM, there's pretty rigid criteria in order to diagnose someone with any of the previous eating disorders we were just talking about. And so if they don't fit neatly into that box, we have this kind of catch-all diagnosis, where they have some symptoms or characteristics maybe of a couple different types of eating disorders, but they're not meeting full diagnostic criteria for that, but we definitely know this is inhibiting their daily functioning. So with this, we might see night eating syndrome, where someone could be eating throughout the night, maybe consciously or unconsciously. Orthorexia, the very high focus on clean eating or healthy eating. I feel like this really spiked during COVID when social media was kind of the way that we were all just interacting, and people were putting their exercise videos and those sorts of things online. We saw a large spike in clients focusing on their clean eating or what was their workout regimen for the day. Diabulimia is something where clients who have type 1 diabetes can manipulate their insulin in order to manipulate their weight. This is obviously very serious in messing with the insulin and messing with their overall functioning of their body. The most common type of diagnosis that falls into OSFED is atypical anorexia. There is a weight component in being able to diagnose anorexia, that someone is under what their expected body weight should be. However, we see clients, especially kiddos who are struggling with eating an appropriate amount of what their body needs for an energy intake level, but their weight hasn't dropped to an abnormal BMI or an underweight BMI. It's still anorexia, we're just we're not able to diagnose it in the same way. As describing these things, you can see that these are no less serious than if we have someone who fits very neatly into the box of anorexia, bulimia, or binge eating disorder. These can be very serious as well. Then unspecified feeding and eating disorder. This is where the symptoms and characteristics of feeding and eating are causing clinically significant distress or impairment, but they're not falling into fully meeting criteria for one of the diagnoses. So it started as disordered eating. We're leaning towards it being an official eating disorder diagnosis, but we don't have all of the information yet to fully make this diagnosis. This is where this diagnosis can come into play. And then the last two to briefly go over is rumination disorder. This is where there's repeated regurgitation of food for a period of at least a month, which means that someone is chewing and swallowing their food, bringing it back up into their mouth to chew and swallow again, or potentially spit out. There is a belief with this that if I re-chew and swallow my food again, I'm breaking down the food even further and I'm not able to absorb all of the calories in the same way. It is not due to any other medical condition, and it does not occur with any of the other diagnoses. This can be a symptom of another eating disorder. It can be a way that a client is engaging in some form of compensatory behavior, but it can also be its own diagnosis as well. And then pica is persistent eating of I'm just going to skip that word, non-food related things for a period of at least a month. It is inappropriate to the developmental level of an individual. It's not part of a culture or socially normative practice. So this is where we can have people eating things that are such as dirt or cravings for laundry detergent or those sorts of things that are just not nutritionally appropriate for someone to ingest and that they're engaging in for at least a month.
So, some overall general eating disorder statistics. These are quite impactful, in my opinion, just with some of these numbers that we'll review. But according to the 2019 WHO, you can probably anticipate that this number has only gone up, but approximately 14 million individuals worldwide, including 3 million children and adolescents, grapple with eating disorders. About half to 3.5% of females suffer from anorexia, and over 90% of these folks are adolescents and young women, so maybe from 18 to 25. Um, about 1 to 4% of females suffer from bulimia nervosa in their lifetime, and 2.2 to 5% of Americans, so really almost double, experience binge eating disorder in a 6-month period, making it the most common eating disorder. So there's another slide we're going to show you just to really bring home the point that we hear often about anorexia and bulimia, but truly there are other eating disorders that are even more common than these two. Of 1,600 adolescents surveyed, about 61% of females and 28% of males engaged in disordered eating behavior. So, right on the cusp of eating disorders, and about 11% would qualify for an eating disorder diagnosis. Now, remember, take these numbers and then add some, because a lot of this is self-reported, and people typically tend to report less than what's actually happening. And an interesting stat as well, rates of male hospitalizations have risen by 70%, both due to the increase in prevalence of eating disorders and awareness of men or boys with eating disorders. And that eating disorders are not just specific to women. Another statistic that I wanted to share with you, just in relation to COVID, some of these stats, or you have different stats really on each study, but ARFID, for example, increased by an average of 300% after COVID. I think there's an increase in awareness there about excessive picky eating and ARFID, but that's huge. Binge eating disorder increased 81% after COVID. Anorexia increased 73% after COVID. And then about 40% of patients report onset being affected by COVID or exacerbation of symptoms being affected by COVID. So we saw a major increase, especially in kiddos. Just, you got to wonder how much social media affects that as well, which we'll talk about. This is just a graph to really go through like the fact that the orange there is binge eating disorder and the commonalities of the prevalence of eating disorders. So anorexia and bulimia, there's not ARFID on this chart, but anorexia and bulimia are the least common eating disorders. And so those are the eating disorders that we know most about, which that is a problem for our treatment in society. So a lot of advocacy for research in eating disorders that are not around anorexia and bulimia in our professional world. And then some other interesting facts about kiddos in this world. It's somewhat depressing. About 81% of 10-year-old children are afraid of being fat or afraid of weight gain. And that's a fear that our society and other factors have instilled in our children. 35% of adolescent girls engage in crash dieting, fasting, diet pills, or laxative use. Which is insane to me, because those are pretty significant behaviors. 50% of Black teens are 50% more likely than white teens to exhibit bulimic. Oh, sorry, I keep on pressing this. bulimic behaviors. 91% of college women admitted to controlling their weight through dieting in a survey. And some of these rather astonishing statistics, eating disorders are the second deadliest mental illness. First is opioid overdose. It used to be the first prior to opioid epidemic. And then every 52 minutes, someone dies as a direct result of an eating disorder symptom. So it's pretty staggering how important this issue is and how many people know very, very little about it. You guys feel free to, if you have any questions about the diagnoses or the signs and symptoms of eating disorders or the stats, feel free to ask them in the chat.
Thank you, Melissa and Sam. If y'all do have any questions, please put them in the chat or raise your hand and one of the panelists can call or can get your question and send that our way. We do have a question. What is GI issues?
Yeah, sorry about that. Sometimes we're in our world so much, we use acronyms and abbreviations for things, and we automatically, assume that everyone knows what that is. It is gastrointestinal issues. So anything that involves the colon, the upper intestinal tract, the stomach, the esophagus, anything along your intestinal or gastrointestinal tract in the body, it refers to GI issues.
Okay. Another question. What about an individual that severely restricts food intake? Whoa. And also excessively exercises? What would that fall under?
So I'll let you chime in, Sam, if you want. I'll kind of address that at first. It's really based on individual presentation and depending upon amount of exercise, like what does actually excessively mean, and what does the food restriction, what does that look like? And so is that anorexia or is that bulimia? Typically with bulimia, we may not see as much food restriction, but more excessive exercise for compensatory behaviors. Whereas an anorexia, that may also fall under anorexia purge type. It gets kind of complicated there. I'll let Sam add on to that if you have anything.
Yeah, the only added thing for that is with anorexia, there is a weight component to it. So if they're drastically under what their weight should be, or it unfortunately still uses the BMI for some of that diagnostic criteria. So where they fall in the BMI scale as well, we'll kind of differentiate it between anorexia or bulimia. But I think that's where we also end up seeing a large amount of our people diagnosed using that OSFED diagnosis, where it could kind of go either way. And so we use the other specified feeding and eating disorder as kind of that catch-all if we're not 100% sure.
We've got several more questions in the chat, so I'll read a few of them and we'll answer questions until 9:55 and then we'll transition to the next section. So next question, how do you determine the difference between picky eating and ARFID in young children, especially those with ADHD or ASD?
That's a great question. I think as what we were just describing with the last question, there's a lot of nuances with the diagnosing. And I think, and Melissa, I want you to chime in as well from the dietitian perspective. But it's more, what is that level of interference with their ability to grow? How much is it impacting their daily functioning? Is it slight picky eating where, yes, they have certain preferences, but it's not impacting those daily things? Or is it we're prepping a lot of food ahead of time? We have to know that they're going to have this certain type of mac and cheese. And it's kind of inhibiting the rest of the family system of their ability just to engage in normal life. Would kind of differentiate it between picky eating and ARFID. But
Yeah, like for example, if someone's on a stimulant for ADHD treatment, then and that stimulant is causing them to have a reduced appetite, that necessarily wouldn't be ARFID. They could have a failure in growth if they're not eating adequately, which we do see patients, and that would be more disordered eating due to a secondary to a stimulant use. But every kiddo is truly different. We've seen kiddos that are on stimulants for ADHD or not, and they do have excessive picky eating. And I also want to hone in on the fact that some parents and providers are so concerned about vegetable intake and fruit intake that they say, hey, yo, my 5-year-old is not eating any vegetables. Well, that's pretty typical for a 5-year-old, for example, even a 10-year-old. And so, what's actually realistic for that age group and their preferences, versus what is truly restrictive, fear-based, anxiety-related issues around food variety. So.
Okay, there is a lot of questions to get
I
through, so we're not going to get through all of them, but we'll circle back to them throughout the presentation. Next question is, so for pica, would that include eating ice constantly, or is that more of a non-food items?
Pica really falls into that more non-food items. So ice would not fall into like a harmful food. Like there's no harm in ingesting ice versus something that could be a non. So they could eat paper or tissues or those sorts of things where ice is not adding any nutritional value, but it's not taking anything away either.
Is it common for individuals to move between different disorders, and which disorders more commonly morph into another?
Definitely common.
Mhm.
For someone because a lot of the times the roots, like in what Sam does with therapy, it's similar. It's just the coping mechanism of choice may be a little different. Yeah, I don't necessarily see specific eating disorders morph into others most commonly. I have seen, which is kind of fascinating to me, something that starts out as ARFID, then as someone goes through teenage years, really transforms into anorexia. I have seen that, which is fascinating to me. There is a body image component then. Um, anyway, you have anything on that, Sam?
No, I agree with what you're saying, and I don't know, that was the one I thought of as well, is kind of that picky eating into an potential anorexia diagnosis, or binge eating into anorexia as well, where they may have engaged in binge eating out of restrictive patterns, and then the restriction becomes their main coping skill as well.
One participant wants to know if we'll get into co-occurring mental health or other concerns that go alongside disordered eating. They work with an agency that supports survivors of sexual assault, and they can struggle with disordered eating oftentimes.
Yes, we will absolutely get into that.
Okay. Another one says we can circle back to that question, so we will. So we'll have one more question and then we'll move on to the next subject. Can you say a little bit about any link between BDD and ED? Can they be diagnosed together, or is one exclusionary of the other?
Was that BDD?
That is what is typed in the chat.
I don't.
That was me, body dysmorphic disorder.
Got it. Thank you. I was like behavior. There is a body dysmorphia component to most eating disorders, but it may not necessarily be a separate diagnosis. Usually that can be a body dysmorphia diagnosis will be means there's not necessarily an eating disorder component to it, but all eating disorders outside of ARFID have a body dysmorphia diagnostic component to their the diagnosis. I feel like I've said that word a lot in the last hour. So I don't know if you have anything else to add to that, Melissa.
No, I'd say probably, yeah, to agree with you, Sam, it's like it's very commonly connected. And have you seen someone with BDD exclusively?
No, but usually it's not something currently working in higher levels of care. It's not something we're going to get a lot of insurance coverage for. Unfortunately, I think that's also why we see back to that prevalence we were talking about with we focus so much on bulimia nervosa and anorexia nervosa, but the most common ones are OSFID or binge eating disorder. I think a piece of that is because of the insurance companies that we work with and just the realities of coverage that we're going to get for higher levels of care.
Yeah, sure.
Well, Melissa, Sam, thank you so much for this first section, and we are ready to carry on into your presentation.
Okie dokie. So the next part of our presentation is reviewing what we call the gold standard of treatment and the different levels of care for eating disorder diagnoses. And remember, disordered eating is really prevention of all of these things from happening. So if we can catch a kiddo in disordered eating and that doesn't progress to an eating disorder, then fantastic. But this is what higher level of care or what treatment looks like for someone with an eating disorder. So you guys can have an understanding of how you're referring clients or what they possibly need in their treatment. Okay, so first thing when you're looking at referring someone for, well, first I'll refer out. If you notice your client or your student may or may not have an eating disorder, it's important to help them, or if you're a parent, build a treatment team. So it is also very important to find eating disorder trained team members. That can be exceptionally challenging if you're not plugged into this world. So you can always reach out to Sam or I for that plug in. And I will explain why that is important, especially in the nutrition world, having someone who's eating disorder trained. You do need a therapist on board to treat eating disorders, a registered dietitian, not just a nutritionist. I giggle because that's a big topic of discussion in our world. A medical doctor who preferably knows eating disorders, but that's very hard to find. And then a psychiatrist. And same, kind of theme there is eating disorder aware, at least, for the medical doctor and the psychiatrist. And Sam, I apologize. I can't see the page numbers, so I think I'm going on this slide, right? Okay. So we chopped this up here a little bit for ourselves, so can't see the page numbers. Woohoo! Levels of care for eating disorder treatment. So we're gonna go, there's an arrow down there on the right-hand side, and it's from highest level of care to lowest level of care. So if someone is engaging in excessive eating disorder behaviors or from a mental health standpoint has SI, then emergency room or hospital stay. This is when folks may have a heart attack or may pass out. And typically this is for the most acute and it is not long-term treatment. It is to get truly medically stable. And then that typically is not eating disorder specified. So that's usually just general health and medicine. And then our next level of care is inpatient, which I would say most folks, not necessarily, if they're acute, they're going to go directly to inpatient eating disorder treatment. And typically, depending upon insurance, as Sam was saying before, we're lucky if we get a 45-day stay in inpatient, but anywhere from, I'd say 15 to 45 days, even less. And since I'm outpatient, Sam can chime in here if you need to, but it's for continued medical and nutritional stabilization and supervision. So 100% like ongoing treatment. There's some therapeutic work in this level of care, but really the focus is stabilizing the person and their internal functioning. There are individual therapy and nutrition sessions, and again, tend to be focused on stabilization. So think of inpatient as stabilization from a mental health component and a physical health component. So when I worked in inpatient, sometimes my nutrition sessions would be 10 minutes, whereas outpatient, they're 50 minutes. So there's a big difference there in someone's ability to sit and talk with you or not focus on the eating disorder while they're talking to you. The next level of care is what we call residential level of care, and that's typically a 30 to 45-day stay for medical, nutrition, and therapeutic work. There is overnight supervision, in residential level of care. And folks are typically medically stable in residential, but they need monitoring via nursing. So a physician may not come to visit them every day in the inpatient setting, but a nurse is there a lot of the time to monitor them. For behaviors and low motivation, I say low motivation because that's a factor in assessing for a level of care that we'll get to. There are individual therapy and nutrition sessions weekly, sometimes more than once a week. That's actually a really good thing, I think, when looking for a higher level of care treatment center, along with regular medical monitoring. Our next level of care is partial hospitalization, which is also known as PHP. This is essentially day treatment. And I've seen all different kinds of programs from 6 hours a day to all day. I've seen them from even 7 days a week in PHP programming, but typically 5 to 6 days per week. Folks are absolutely medically stable. Typically, clients are in this level of care. I've seen clients in this level of care for 60 days before, but typically 30 to 45. And really, individual therapy and nutrition appointments become a bit more, not that they're not meaningful in higher levels of care, but they become more in depth. They become more collaborative because as your brain awakens and recovering from an eating disorder, and you're living your life outside of treatment, you're not in a residential care facility, then things become a little bit real, and you're navigating your day-to-day life outside of PHP and your recovery. There are medical check-ins for PHP as well as needed. And then you have intensive outpatient programming, which PHP and IOP during COVID times transitioned a lot to virtual programming. Can you imagine being on virtual programming for 6 to 10 hours? It's like in addition to school type of thing. Um, and that's a lot on virtual. So a lot of people skipped over IOP during COVID and went straight to outpatient, which we don't recommend. But intensive outpatient programming, or IOP, is typically 3 hours, 3 days a week. There are still virtual programs, of course, along with PHP, but there are more in-person programs as well that have returned post-COVID. And this is mostly group work and finding a community with nutrition and with therapy. Depending upon how the program length works, I see folks in here for 30 days, 30, 45 days as well. And then this is really where folks will establish an outpatient treatment team. So that's when they'll come to me and an outpatient therapist, and an outpatient or a medical provider or a psychiatrist that they'll really see hopefully long term in the outpatient world. Some programs recommend to see outpatient treatment team in conjunction with IOP. I do want to preface, it's important to the population that we're talking to right now, is that with all of these programs, school is taken care of. A lot of programs have teachers that are hired, so students will get assignments from their classrooms and spend 2 or 3 hours a day being taught, depending upon their curriculum and their grade level. So you don't miss grades like you used to. So I say that because a lot of people deter from treatment because of school, believe it or not. So of course they don't want their child skipping out on senior year in high school. right? But the eating disorder is truly allowing that to happen. So concurrently doing school, you still can graduate type of thing while you're getting the treatment that you need. And then outpatient level of care typically looks like seeing your providers 1 time a week, therapy and nutrition, and then medical as needed. Typically once a month at first, and then transitioning to once every 3 months as someone becomes more stable in their outpatient world. And that's more of the long-term care. Whoops, I switched sections there. Hold on. Let me go back. Yeah, okay. And I think this is where I'm done, Sam, right?
Yep.
Okay, perfect. All right.
So as Melissa was talking about, there's a lot of factors that can go into assessing what is the right level of care. There's a lot of levels of care, a lot of nuances in that. I will preface it with wherever you start, if someone does need anything above an outpatient level of care, following that continuum and not skipping a level shows the best efficacy of getting to a fully recovered life from an eating disorder, especially when there's students. There can be this added stress of school, not wanting to extend time in school or making it to college in an appropriate time. And I try to remind people that college is always going to be there, school will be there, but we need to focus on getting the eating disorder under control in order to be able to appreciate those things in life and be able to enjoy them and not having to continue to go back to higher levels of care. So as you're thinking of all of that, all of those different levels of care, the things that we're going to look at when choosing a level of care is which environment is going to be the least restrictive in order to provide the most support. We don't want to jump right into someone needing a higher level of care if they don't necessarily need it. And they're there for a reason. So we're going to look at medical complications. As Melissa talked a lot about, there's a lot of things that can go on in your body that we need to be aware of. And if we're seeing some of those major organ systems not be able to function properly, then we're going to lean towards those higher levels of medical stabilization, inpatient, residential, where there's a lot more medical oversight, versus if we're not seeing so many medical complications, we go on the lower end of that spectrum. Suicidality is a big piece of it. I don't think I've ever seen an eating disorder occur in isolation. There's so many other co-occurring diagnoses that show up. The eating disorder is serving some function. And a piece of that can be suicidality as well. So is there safety concerns? Does someone have a plan or intent? And that again is going to go to one end of the spectrum of that more severe, safe environment versus being able to stay outpatient. How much weight does the person have to gain? What percentage of their healthy body weight are they at right now compared to where they need to be? If there is significant weight gains that we need to accomplish, that may be easier to do in higher levels of care where there's a lot more support. You may, especially like residential inpatient, you're going to have staff with you with the kiddo to be doing support for those meals and making sure we are intaking an appropriate amount of energy intake. Compared to outpatient, there isn't as much of that oversight. What is the client's motivation to recover? If they have zero insight that this is a problem, we may need to go higher in their level of care than starting lower. If they are motivated, they're doing the things, they're following their dietitian meal plan, which is, I'm sure speaking for Melissa, a dream of any eating disorder client to follow their meal plan, then we could probably stay more outpatient. What other medical or psychiatric diagnoses are we struggling with that may need more or less oversight? How much structure is needed for the individual? Do they need a lot of support, a lot of that professional trained staff to provide that care for them and be providing them skills and check-ins throughout the day or not? How impaired are they in their ability to take care of themselves? So it's ADLs is another way of saying that. Are they consistently showering, brushing their teeth, just overall taking care of themselves, especially when there's a body image component to the eating disorder? We can see clients not wanting to shower as much, not wanting to be in the mirror, not wanting to be around their body without clothes on. So we can see an impairment in their ability to take care of themselves. How are they able to control over exercising if that's a behavior that they have? We have lots of clients that, especially the majority of the facilities I oversee are residential. And so sitting down, relaxing on the couch, not pacing around our milieus can be a big behavior that we want to help curb. What is their purging behaviors? As Melissa also described earlier, purging can come with some pretty significant internal damage, depending on how long it happens. And so how much are we able to support them and curb some of those behaviors as well? What is their environmental stress? The family system is a huge component of the work that we do. Eating disorders don't occur in isolation. We need the entire family system to be able to support someone who's moving forward in their recovery. So how engaged is the family able to be? There's other barriers of life circumstances, and maybe family can't be as involved or monitoring as we would ideally like them to be. So maybe we need to kickstart that in a residential level of care before we move back down, and providing some of those tools in a family therapy session. What is the treatment ability and availability? How available are options for them? If we're looking more PHP, IOP, or that day treatment, we may not have access to those places. Or yes, virtual care has become a huge, we've seen an increase in the amount of people engaging in that type of treatment. However, it's not appropriate for every client. It does give us so many more people access to a higher level of care, and we're still hiding behind a computer screen. So some clients, it's not going to be necessarily the best level of care for them to do it virtually. And what is their living situation? Who is available to support them? Are they trying to do this alone? Or do they have family caregivers that are able to support them in their recovery process? So then when you're looking at a potential program for that higher level of care, you want to look at the amount of structure. What does the program give you? Does it have a teacher associated, especially if there's an adolescent? What type of school are they able to engage in? How are we providing the structure for the work that they're going to do? Is it very prescriptive, or is it individualized at all based on what the person is needing? What protection are they needing? Are they needing protection from themselves? Do they need a lot more restriction in those things? Or are they able to have their own autonomy, accountability? They have some of that own engagement themselves. How are they able to organize their day along with the family and the staff? How much support are we needing from external providers for that work? And what is the way for avoiding power struggles? I'm going to talk a little bit more about this later on, but we will never out stubborn an eating disorder as a provider. So how are we incentivizing some of those things that are going to be like the positive reinforcers or those negative consequences for them to do the things that we're hoping they do and get that own internal motivation without just meeting that the behavior that we're seeing with a power struggle? How are we helping them develop their own motivation? I can't force recovery on someone as much as I would love to. And there's many times that I've wanted recovery a lot more than the person sitting in front of me. So how am I helping them? How is that program helping them develop their own motivation for recovery? What social support are they needing? Do they have friends that are engaging in behaviors as well, or do they have social supports that are available for them? What is the program's way of working through the system? Is it 30 days regardless? Is there ways to extend that? What is the amount of time that you think you need for that loved one to be able to work through it? What are the clear markers of progress? What are you wanting to see? Making sure that especially if it's a higher level of care and you're referring out to them, you want to make sure that you're able to provide information on what you've seen with that client since you've known them longer. What is that communication with that higher level of care or lower level of care? And goal setting. How is the client involved in the process so that they feel that they have some autonomy in the work that they're doing? A simple screening tool that is free, it is super blurry on here, I'm realizing, is the SCOFF tool. So this is a quick and easy way of assessing kind of eating disorder function. Other things you can consider is the eating disorder examination questionnaire, the eating disorder inventory 2 or 3, and the eating disorder quality of life skills. I think the SCOFF is the easiest one, especially if you're in a lower level of care, just to look at, do you make yourself sick because you feel uncomfortably full? Do you worry that you have lost control over how much you're eating? Have you recently lost more than 1 stone? You can tell this is not originally written in this country, so a significant amount of weight in the last 3 months. Do you believe yourself to be fat when others see you as thin? And would you say food rules your life? So these are certain things you can kind of get the basis of what you might be working with and what struggles you may need to explore with someone moving forward. Right. I think that's a great place to pause for a second to see if there's questions before we go into perceptions and stigma over time.
Again, put any questions that you have in the chat. I will revisit a few of the lingering ones from last time while folks type. So we did have a question pop up. What's the significance of referring to a dietitian versus a nutritionist for eating disorders?
That's a great question. So the term dietitian and nutritionist are they're used interchangeably, right? And so even the credential, we've added registered dietitian nutritionist RDN to the RD credential, registered dietitian, because of the confusion. The risk that you have with hiring a nutritionist, okay, not a dietitian. So you want to look for the RD, is that the term nutritionist is not regulated. So anybody could call themselves a nutritionist. My 6-year-old could call himself a nutritionist. It is not regulated, especially in the state of Texas. Now, some states have higher regulations, like they have certain criteria. You can't actually call yourself a nutritionist if you have XYZ. Texas is not one of those states. So you want to be very careful with referring someone out to a nutritionist. You want to look for this certification RD or RDN. And the reason behind that is, and I won't spend too much on here, this is kind of like a talking point for me, but dietitians are regulated in their training. They have to pass an exam. They have to get a master's degree. Now, they have to go through certain things. Now, I will also say that on top of the RD, you want to make sure that the dietitian that you're referring to has eating disorder experience, because we're in such a small niche that you want to be able to not refer to someone who specializes in weight loss. Okay. There's a big difference there. And you want to make sure that that dietitian, and I'll explain a little bit more about this in the following slides, but a dietitian does have truly not just a listed 30 specialties in eating disorders included in one of those, truly has eating disorder experience. You can look for the CEDS credential. You'll notice on our names, we have at CEDS or CEDSC. That just means we have additional training from an association that provides that training for eating disorders specifically. But not everyone specialized in eating disorders has that credential. So if you're concerned about if someone has eating disorder experience, give them a call. But that's the difference. That's what I mean by nutritionist and dietitian.
Thank you.
Mhm.
We have another question come up, which I also want to know the answer of. Treatment resources have been hard to find. Do you have any recommendations for finding good resources for our clients?
Go ahead, Sam.
Yeah, I would say our field of eating disorders is not great at providing access to care, especially for anyone who may be Medicare, Medicaid. Speaking for the company I work for, Montanito, our intake assessment department is free. And so anyone you're able to call in, even if we don't take the insurance that you are looking for, we can help connect you with resources. Our admissions department has a list of outpatient providers for wherever you may be coming from. So if it's from the Dallas area and maybe you're not meeting criteria for that higher level of care, but we can connect you with Melissa or someone that is able to build a treatment team for you. So usually those higher levels of care can help connect you to resources beyond just like Google to try and find, especially when you are trying to filter through sponsored ads and those sorts of things to find something that is more applicable. I think the other thing is looking at what is the specific type of diagnosis that you're working with or other co-occurring disorders as well. There are programs that are more better suited to treating clients who may be neurodivergent or on the spectrum at all, that other programs may not be as equipped to treat, not because they're any better or worse than the other, but just there's, if you say you're good at everything, you're probably not great at anything. And so how do you finding that program that is specific to the needs of your specific client? Speaking for Melissa and myself, our contact information will be at the end of this presentation, and we are happy to support anyone to try and connect them to the resources that we may know as well in the community.
I'm going to circle back to a couple of the previous questions in our comment section here. This person wants to know they are working with a client who is a nonverbal 2-year-old who has experienced food insecurity and often overeats to the point of making themselves sick. Would you expect the behavior to change over time in a new environment, or at what point should the concerned parties intervene?
I think that's an incredibly difficult situation, especially with someone that young, who is not going to have a lot of verbal processing abilities. That is, we see a lot of binge eating struggles come out of food insecurity, especially from a place of, I don't know when I'm going to get food again, so I need to eat as much as possible now to help sustain me until that next time I have food. So you can, as they get into a stable situation where they know that they have access to food, you will hopefully see that reduction. But I think getting them connected with any sort of child therapist would be great. Someone who may be trained in play therapy, because for someone that young is not going to be able to engage in typical talk therapy to kind of process through some of that. But the biggest thing will be consistency in a stabilized area where they know that they have access to that food, and not trying to restrict it, because that's going to fuel some of that insecurity, even if it's out of a place of like trying to help them know that they don't have to get to that point of being sick, but letting them know that food is always available if they're in a place that they are able to access food consistently. I don't know, Melissa, if you have any other thoughts on that.
Yes, totally agree with you. Don't restrict the food intake to counteract any kind of binge eating or overconsumption, because that actually fuels more binge eating. So that's where binge eating comes into, it's actually truly a restrictive eating disorder. So I would definitely keep an eye on the kiddo for sure, and the therapy component, because that is such a risk factor for the connection with binge eating disorder, at least they know.
Okay. We've had one final question come in. We will answer this one and then move on to the next section. So, is there any socioeconomic trends with eating disorders, or does it occur at the same rate?
There is a perception. I think we're working to challenge it better now than we have in the past, but that eating disorders just occur in affluent white women, and that is not the case. They do occur, we're more likely to see a woman, specifically Caucasian, diagnosed with an eating disorder, but they do not discriminate based on age, gender, socioeconomic status, or anything like that. They can show up in different ways based on those communities, but it is not only in certain socioeconomic statuses. Mhm.
Yeah, I think treatment access has a lot to do with that as well. Just insurance access too, and level of awareness of eating disorders and how they present. It's not just anorexia and bulimia, you know. So, yep, I agree with
And
Sam.
yeah, I think there's a cultural component to that too. I'm going to talk a little bit about this shortly, but just perceptions of what body size should look like, and how that can impact an eating disorder can occur in any body size. It's not just someone who looks emaciated. So I think challenging that stigma as well, to look at just overall how are they functioning with food and how much of food or compensatory behaviors are ruling their life. That it's not just someone who's not eating, is a big piece to that too.
Yeah.
Well, with that, we will continue on to learn more about interventions and other factors in eating disorder treatment.
All right, so now we're going to go into perceptions and stigma over time, along with interventions, both from the dietitian perspective and the therapist perspective. So kind of how we end up getting to a place of eating disorders. Not all diets will become eating disorders, but most eating disorders started as a diet. So the dieting cycle looks like this desire to be thin. We have cultures that tell us what is our body size supposed to be, what should we look like, what is the number supposed to say on our clothes, on the scale. So we have this idea of what we should be. Then we engage in some form of diet, whether it's keto, no carb, no fat, all fat. Insert diet of the day that our culture tells us that we need to be will usually result in some restriction of a food group, or a type of food. Because of that, when you tell yourself you're not allowed to have chips, that is the thing that your brain is going to then fixate on. So you're going to have an increase in cravings and a reduction in self-control, which will ultimately lead to a loss of control, overeating, or mindless eating, which then results in weight gain, and we start this process all over again. Our body is not designed to be on a diet. Our body is designed to survive, and when we engage in a diet, our brain is not able to differentiate between a diet and a famine. So it is thinking food is scarce. So the next time you're eating, it is holding on to everything so that it knows that it can stay alive. That's all it cares about. It does not care if you're a size 2, but that you are living. And so you will see that weight gain in our bodies. And I know Melissa's going to talk more about this in a little bit with Health at Every Size, but our bodies are naturally designed to stay at a certain range of weight. If you're not engaging in any compensatory behaviors or dieting, our bodies will hover in a certain range. When we engage in dieting, we're actually increasing that set point, so that our body stays safe. So some side effects of dieting that no one ever talks about, and this comes from a book highly recommend called Just Eat It. It's pink with a donut on it, like this little graphic, is that we end up binging at times. We're going to slow our metabolism. You may see a loss of muscle mass. We're going to have rebound weight. Become obsessed with food, some disordered eating. We may lose our innate hunger and fullness cues, and have shame, guilt, and anxiety. If we're thirsty, we go get water. If we have to go to the bathroom, we go to the bathroom. But when we're hungry, a lot of times we're thinking, when was the last time I ate? When it's too close to going to bed, what did I eat today? I really shouldn't eat. And we're questioning those innate things that our body is designed to do for us to function. So then we have this thin ideal. So the thin ideal internalization refers to the extent in which an individual is cognitively buying into socially defined ideals of attractiveness and engages in behaviors designed to produce an approximation of ideals. So what do we see through the internet, through TV as what our body should look like? And what are we doing on a daily basis to get closer to that, if anything? And like this picture, on average, in 2018, there was a study done where on average there's 2 billion photos posted every day to social media. And that was 6 years ago. So I can only imagine how many photos are posted to Snapchat, Instagram, Facebook, TikTok, probably some new social media platform I don't know about. And how are we internalizing all of those things that we need to be? So I think a study that is fascinating, even though it was done in the 90s, I think it is a really good example of this internalization of the thin ideal. So Becker and his associates surveyed 63 Tahitian girls in the 90s, 1 month after American television began to be beamed via satellite into the country. Tahitian culture at this point had very low rates of eating disorders, low rates of body dissatisfaction prior to the introduction of American television, and the cultural female body ideal was larger and rounder. They measured a similar group of girls 3 years later and found that 15% of girls reported engaging in self-induced vomiting to control their weight, which is up from 3%. 29% had high scores of eating disorder risk, which was up from 13%, and the preferred body image had actually shrunk and was now thinner. And so, as I said, in 2018, we have all of these photos being posted to social media every day. And so this was done in the 90s. And I think of as an 80s, 90s baby, the type of television we were familiar with at that point was yogurt commercials telling you if you ate this yogurt, you would fit into that bikini. And all of those commercials that are telling us that if you do X, you will look like Y, when in reality, we know that's not possible. We all have different body sizes, and your weight is so much more controlled by your genetics than any sort of thing you're going to do in your daily life. So some cultural influences as well there's this idea of normative discontentment. And so this was founded in 1984, and it's very normal for women to feel discontent about their bodies. It is normal in friend groups to talk about, oh, I wish I could change this about my body, or I wish I was this size. And men are starting to experience that a little bit too. It is abnormal for us to talk about maybe feeling good about our size or shape. To accept our body the way that it is not something that we typically see in our culture. It is not as accepted. It is definitely the minority. And so this internalization of the thin ideal, as I've talked about in the last few slides, is a very powerful causal and maintaining factor of eating disorders or the potential to develop an eating disorder in the future. Some historical things that are fascinating, and a lot of this comes from the book called I'm blanking on it, and we'll tell you in a moment when it comes to me. 81% of human societies in documented history have had beauty ideals that were in larger bodies. And so how did we get to this point of where we're at in our culture is very fascinating. And so the statement, "you are what you eat," actually came from Spanish settlers who did not want to turn into the indigenous people of the Americas. And so if we eat like them, we will then look like them, and we wanted to be differentiated. During World War II, there was actually a shortage of food, so the government created the Food Administration to create rules and standardize the way that we ate based on food conservation. And the thinner ideal really developed around a similar time frame when, quote, stout and sturdy immigrants came to this country and we wanted to differentiate from the immigrants who had been here longer versus the newer ones coming. So historically and today, we engage in systemic discrimination between men, women, culture, and around body size. And it's going to drive me nuts until I think of what that book is that I will hopefully think of soon. Anyone can be impacted. Like one of the questions that we were talking about, eating disorders do not discriminate based on race, gender, age, socioeconomic status, anything like that. We have seen eating disorders diagnosed as young as 7, and up to people who are in elderly age as well. 50% of the Black, Indigenous people or people of color will develop eating disorders, are half as likely to be diagnosed and receive treatment. So again, just because we're not seeing it as popular in higher levels of care doesn't mean it's not happening. 29% of LGBTQ plus youth stated that they have been diagnosed with an eating disorder. And additionally, 29% of that group state that they haven't been diagnosed, but suspect that they may have an eating disorder. And again, anybody, if you take nothing else from our presentation, anybody can have an eating disorder, any gender, race, ethnicity, age, or size. So some barriers to care are weight stigma. There is a discrimination or stereotyping based on someone's weight. And so as I mentioned earlier, clients in larger bodies, clients who may struggle with binge eating disorder may not have the same access to care based on their insurance company and what they're willing to cover just based on the immediate medical need that the insurance company dictates versus what we think would be the best one. Again, eating disorders occur in any individual in any body size. We want to make sure we're looking at gender inclusive care. How can we create an environment that's safe regardless of how someone identifies? Insurance coverage is, I'm not going to go on that soapbox of how frustrating that can be, but making sure we're trying to, that is a huge barrier for kiddos to be able to have access because the cost of treatment, both financially is pretty great, but also the family to miss work or school in order to get a client into care can be a lot. And so there's a lot of barriers that could be in the way of someone being able to work towards a recovered life.
Okay. So moving away from the BMI, there's a lot of discussion, and BMI, for those that don't know, are body mass index. You see this on your health record, probably at the top highlighted in bright pink, for some reason. And, we as an eating disorder community and really from a health standpoint, moving away from BMI. And here are some of the reasons. It really focused on standardizing the population of a white European man in the 1800s. So it's not really BMI, and the concept of it is not a measurement of health, but it was used for a tool for probability. So it was really meant for noticing trends in MASH populations. So it wasn't ever meant to be a dictator of someone's individual health. And unfortunately, we have those categories of BMIs, right? 25 to 29.4 or 21 to 20, all those different ones. Over 30 are considered a certain category, and then what level of obesity. And that really and if I'm just going to be completely just transparent here, that's a bunch of just it's a load of crap in many ways. And so we really don't pay attention to BMI. Unfortunately, insurance does. So just a little history here. In 1899, the president of the Association for Life Insurance, medical director of America, used the skewed data to inform how they covered benefits. So really a limitation of benefits. And then a lot of people don't know this. And why would you if it wasn't something that was totally publicized? But in the mid 90s, the ranges of BMI were changed by the WHO and the International Obesity Task Force. And there's a lot of conflicting financial ties to the reason why some of these things were changed from a pharmaceutical level. One of the big things now are the GLP-1 medications for weight loss that I can talk a lot about, but we're on BMI right now. So BMI truly in and of itself is a racist, sexist indicator of health, quote unquote, that insurance companies and people, including physicians, have been utilizing as something to define someone's internal health, which is just not true.
The Anti-Diet is the book I was trying to think of that I have referenced, that we have referenced there. That is the one that has a lot of this information about like the historical information. Sorry.
Oh, you're good. Yeah. That's a great book. So how may we be contributing? And a lot of things, people are like, oh my goodness, I did not, even think that that was harmful or could be harmful, which is why we talk about it. But by praising another person's or child's appearance based on size or physical attractiveness, hey, I noticed you lost some weight. Good job, right? Without even inquiring about, well, how did someone lose weight? And that's a nuance. Really, in reality, that's not something that should be praised. But it's like a second nature for how we were brought up, at least here. Instead, saying something like, hey, I noticed you handled that situation and the conflict with a coworker really well. Or, hey, I noticed that your friend didn't want to play with you on the playground and you walked away and said, I'll find somebody else to play with. That was very brave versus I like your jacket, right? There's a difference there. Complimenting someone when they lose weight or diet, which really tags into the top bullet point, the word complimenting and losing weight. What if someone does have an eating disorder and you have no idea? You just complimented the eating disorder. You just validated that for them. And that, guess what? You notice what their body looks like and how it changes, which is a huge fear for folks in eating disorders and anyone really. Talking negative about one's body or considered fat talk. And this is a big, the word fat in and of itself. Why is that? We have to ask ourselves, why is that negative? Right. And that's just a word. That's not necessarily to define someone's morality or who they are as a person. So talking about, like, as a parent, for example, going in a dressing room and trying on a new dress and coming out and showing your daughter or your son and saying, man, I've gained so much weight. I look so fat in this, or I look so bad in this. That ultimately affects that child or that person. It's important to you. So why wouldn't they think it's important to you for them? So just because you're not talking about someone else's body shape and size, when you talk about your own, it does affect those around you. Discussing measurements, weight, or clothing size can be very triggering. Oh my gosh, I went from a size 8 to a size 6. Yay. That kind of stuff can be very harmful. Again, for anybody. Why are we focusing on that as an important part of our life? Oh yay, I paid my bills this month. That should be focused on as in this economy, as a victory. Thinking of food as good versus bad. I'll talk more about this in future slides, but good versus bad is a huge thing. This broccoli is good for me. My 6-year-old son comes home and says that sugar is bad for him. Wait a second. What do you mean bad for you? Those developed thoughts around food and categories that really aren't valid and rooted in scientific information. They're rooted in fads. So foods are different from one another. Sure. A piece of candy is definitely not going to sustain you like a bagel will, But at the end of the day, they're all broken down to similar things at different rates. They're just different from one another. Making fun of or criticizing our own or others' eating in any way, like, hey, you eat that really slow, or hey, you eat that really fast, or you're really obsessed with McDonald's French fries. Like saying these things and commenting on anybody's food behaviors or patterns is just unnecessary. And as parents, I know that a lot of times parents feel like they're not doing the right thing by not forcing their child to eat veggies. I did see a question on the chat around like forcing your kid to eat something. Yeah, there's a lot of research around child-led feeding and weaning actually when they're young. And so making fun or that was a little bit of a different subject. Sorry, my brain works that way. But making fun or criticizing someone's eating patterns or your own is just not necessary. Saying someone is healthy or well just because they are thin. Oh my gosh, talk about weight bias there. And you cannot tell if someone is healthy or not based on their body shape and size. And I am here as a provider to tell you that that's true. Seeing all body shapes and sizes with different lab results, with different health issues, you can never, ever tell if someone's healthy, or if that matter, say if someone has an eating disorder based on their shape or size. Allowing the media to dictate what body is in. A lot of what has come about too is the fit ideal and along with the thin ideal. And, I don't really have to explain that, but Photoshop is a thing. And as Sam said before, all bodies are different. And social media creates a light that is not truly real. Common eating disorder myths. These are just a few. There's lots of them. But I'm just going to read through some of them and maybe combat some of them if I haven't already with the actual factual scientific information. But eating disorders are a choice. I just need to tell my loved one to snap out of it. Anyone who has an eating disorder wouldn't wish that on their worst enemy. So eating disorders are not a choice. Sure, you can choose to engage in recovery and make certain decisions, but you cannot choose how much you struggle around eating or not eating. And so eating disorders are not a vanity thing. They're not a choice of just snap out of it, like get rid of that eating disorder. It's a lot more complicated than that. That really has nothing to do with food in the first place. Doesn't everyone have an eating disorder these days? I think that's very common in our younger generations with like the awareness of mental health. And you guys may even have more experience with that, with working with young kiddos all the time. But it's, doesn't everyone have anxiety these days? Doesn't everyone have depression these days? And lots of people do, of course. But that overgeneralizes. And no, not everyone has eating disorders, but there is a high risk for a reason. And we're not overgeneralizing and dismissing that because we think that everyone, and we're overdiagnosing. I need to figure out what I did to cause my child's eating disorder. That's a big thing I see with parents regularly. What did I do or not do to cause harm to my child? And it's so much more complex than that. As Sam and I have talked about, this is something that is based on each individual and how their family dynamics play out, and their genetics. And no one thing or one person can cause an eating disorder for someone. It's just an eating disorder. It can't be that big of a deal. That kind of pairs with the everyone having eating disorder these days. I don't think I have to explain that with just our presentation here. It is a big deal. Anorexia is the only serious eating disorder. We went through and debunked that quite thoroughly. As a parent, there's not much I can do to help my child recover. That's completely untrue. Parent involvement, depending upon the family dynamic, again, each individual needs to be treated as such, but there's absolutely things you can do, like support your child through making positive decisions in their day-to-day life. As long as someone isn't emaciated or extremely thin, they are not that sick. My child is too young to develop an eating disorder. As Sam said, we've seen kiddos diagnosed at 7. Wow. I have a son. I don't need to worry about eating disorders because it's a girl thing. absolutely not true. There's just less awareness. I think females in general have been more exploited in social media and magazines historically, but men are absolutely subject to those things as well. It may appear a little different sometimes from, like someone mentioned, body dysmorphic disorder. But it absolutely is there. I would say about 25% of the population that we work with in the outpatient world in nutrition's male. And unfortunately, we're getting a lot of folks who are male under age 15. And not just with ARFID. Okay, so I'm going to talk a little bit more about this later too. Looking at our time here. Okay, we're good. So there are a few approaches that have absolutely helped folks in eating disorders, and they involve an approach called intuitive eating and health at every size, or HAES approach. And these really encompass an all foods fit mentality. Remember how I had said, no, good or bad food, they are different and variable foods, but we're placing a label on that food that isn't helpful. I'm good or bad if I eat these good or bad foods. Weight does not define health. That's really based in HAES. HAES is really a tool and an approach that identifies multiple pillars of health. And it's not just weight and food and exercise. There are different factors that attribute to someone's health. Like Sam had said, genetics, environment, psychological health. In general, it's not just about weight. And at the end of the day, weight bias is poor health care. There have been quite a few research articles and just opinion-based articles and people's anecdotal experiences that go on and navigate. Well, I didn't even get treatment for my stage 4 cancer because my physician was so concerned about me losing weight that that was overlooked. Or I had a broken ankle, but my physician actually failed to take an x-ray because they thought that it was just pressure being put on by my current body size. I had a client who has to see a liver specialist. Well, guess what? The liver specialist in the note said, I need you to lose 10% of your body weight. Didn't even say it in person to this patient. And the patient didn't show up for the next appointment. That's poor healthcare, right? Yes, that's that person's decision, but there's a lot of shame when you go to the doctor and you're like, did you lose weight, when they talk about it. So, it does challenge societal pressures to diet and the idealization of hunger and starvation.
This will be our last section of interventions before we get to the panel. So we can do some questions just on that part before we go into our last little bit.
Okay, we've had a few pop up in the chat, some really interesting questions. How do you counter the impact of physicians diagnosing children with obesity based on BMI only and they're encouraging caregivers to restrict certain food groups based on that?
That's a really great statement / question. And that is takes a community initiative. I would say what you can do for that individual is referring to a dietitian who, honestly, I'm biased, but most dietitians are going to take a more neutral approach to those kinds of things. But getting them a dietitian. And that dietitian, honestly, a lot of the times I educate, if I can, physicians around like, hey, this is the risk here that we're seeing, and this is a child, and this is the harm that this can cause. So that's a community initiative that's really centered in weight bias and poor healthcare.
Yeah. I don't have much to add to that. I think that is our biggest barrier in just getting to a place of health at every size and body acceptance, is trying to find medical providers that align with what dietitians are recommending, what we see in growth charts, especially with kiddos. It's fairly, I don't want to say easy, but you can see with their growth curve where they should be, because we stay within a typical percentile. And then it is fascinating. You can see when the eating disorder comes into play and what may happen. So messing with that is not ideal. And so I think Melissa and I could probably go off on huge soapbox on this topic, but definitely one of the biggest barriers that we face.
And I think it's
Heather,
about educating,
go ahead.
sorry, I think it's about educating the individual caregivers for sure about like, what does that actually mean? And how can we go forward with not focusing on that? A lot of people see their physicians once a year, right? And so that impact there and finding other providers. There are providers who do not focus on that whatsoever, but unfortunately you do run into providers who do.
This is my own personal question. There's a lot of school site staff on the training today. How should those folks engage with parents and students if they suspect that there's disordered eating present? How do they facilitate that conversation?
Really very tricky. I will say that from a standpoint of eating disorders, you really need to have resources to refer out. So the school counselor doesn't have to be, I think you have an eating disorder, right? I don't think they're allowed to do that. But as far as like, hey, I think that this person would be very helpful for you all to see. I see these patterns, and letting the experts do the work there, because it's such a niche. And so, people get horror stories with, confronting someone, hey, are you struggling? And then like snapping back and irritable, no, and so, but I would have a conversation with the parents and refer out to the resources you have for eating disorders. And then we can help them regardless of insurance, regardless of access, we can always help them.
That starts, I would assume, with a conversation about noticing signs and symptoms and being able to recognize those and provide that kind of education to the parents as well. And then with that resource list. Okay.
Yeah, there are some that have signs and symptoms of certain, like our slides, right? But there are like signs and symptoms of anorexia, signs and symptoms of bulimia, binge eating disorder. And I've actually had like coaches beforehand parents that sheet, and say, hey, this is what we're looking at. This is what I'm noticing. What do you think?
Okay. Another interesting question in the chat. Can you address food allergies and how that can impact eating disorders?
Oh, yes. Food allergies are a very hot topic in the accuracy of testing for food allergies. We've had patients that would come and say, I'm allergic to bread. I'm allergic to gluten. And in reality, are you actually allergic to gluten? So a lot of times the eating disorder can hide behind food allergies. I also will say that those with actual food allergies, with celiac disease, maybe some lactose intolerance, which is very rare. And lots of people have lactose sensitivity, not intolerance. They have GI distress that could happen. For example, undiagnosed celiac disease. Where's the chicken before the egg type of thing of did that cause and can that contribute to an eating disorder? Did the eating disorder contribute to the lack of GI health? There's a lot there, but we do, as far as like food allergy, you think about getting an IgE blood test back that says, I'm allergic to eggs, I'm allergic to fish, I'm allergic to gluten, I'm allergic to soy. And people come there and like, what do I eat? So that can absolutely trigger an eating disorder if someone is falsely diagnosed with sensitivities, not even diagnosed, shown to have sensitivities with food. Because that's so common, I feel like, in the nutrition world right now as well.
Okay, that is all the questions currently in the chat. We are running ahead of schedule, but I will turn it over to you all, I guess, to introduce our panelist.
Well, we have
we have one more section before the
One more
panel.
section, just
Yes.
kidding.
Yep.
We will press on through the next section.
Yeah, okay, no worries. Okay, so let me share my screen here. Okay, and I think we have about what 25 minutes or so to get through this. So interventions. We kind of broke this piece up. And really, from our view, dietitian and therapy. So even though eating disorders have psychological roots, they also involve medical and nutritional complexity. It takes a team, going back to the original, setting up a treatment team to treat eating disorders. Okay, so things to remember. Treatment involves removing the most effective coping skill for the client or the patient. So the eating disorder is the coping mechanism. It is the maladaptive coping mechanism. So increasing emotional reactivity is to be suspected. And then our overall goal is to establish a new relationship with both food and movement. Like, for example, who am I outside of the eating disorder? So if you ask someone newly in recovery or struggling with an eating disorder, like, what do you like to do? The answer becomes really challenging. I like to cook. I like to count my calories. I like to run. And there's like, but actually, who are you? The eating disorder has taken over your identity. So separating that out. And what is the function of the eating disorder? Okay, so the role of the dietitian in nutritional interventions and treatment is just on a very broad level. There's too many nuances to talk about today, but giving you the basics of how the dietitian fits into the treatment team and where their role lies so you can understand referral sources is really to improve overall nutritional health. So looking at labs as a second pair of eyes, we do not write labs, just to be clear. Physicians do that, especially if they want to be covered under insurance. But we are a second set of eyes, going back to that slide saying physicians typically do not have eating disorder treatment training. We really have that viewpoint looking at labs. So sometimes things may not flag low or high, but they may be really close to that. So looking at and writing recommendations for lab orders to the physician and coordinating care is important. And then macronutrient sufficiency. So macronutrients are carbs, fats, and proteins. There are signs and symptoms that show abnormalities and insufficiencies in those types of nutrients as well. We want to empower the improvement of our patient's relationship with food. Notice the word empower. Working in eating disorder treatment, it's extremely easy to treat patients like guilty until proven innocent, right? Like, oh, someone's leading with their eating disorder. They must be lying about this. But people with eating disorders are human just like us. So treating them as that and using positive words and trusting them with certain things actually can help them move forward. I have found in a lot more of a empowering, positive way in the recovery versus saying, I know you're gonna not eat that like you have in the past. That's not a positive statement. The dietitian teaches the individual how to obtain adequate nutrition through food and their environment. So logistics around food like menu planning, preparation, cooking and serving, food to yourself, and then others could be a goal as well. In fact, serving food to others may be a behavior that someone engages in eating disorder behavior instead of eating themselves. But all the logistics that come about with food. We are not born with the innate ability to go grocery shopping. We are not born with the innate ability to cook or prepare food. A lot of the times, the eating disorder has suppressed that function for them, or maybe they were part of an environment where they never really learned. And maybe that contributed to the development of the eating disorder or exacerbated that. So as a dietitian does a lot of menu planning, and what I do not mean by that is writing and telling someone to eat exactly like eat this on this day at this hour. There are certain levels of rigidity and details we go about with each patient depending upon their needs. But a lot of the times that's guiding through and helping someone prepare their own menu. To advocate for accurate nutrition information amongst the fad Fads and societal noise about nutrition. Oh my goodness. I went to a Prosper ISD career thing for high school kids, and it would literally the first question I got was, "Hey, I saw this on TikTok. What do you think about this?" So much misinformation, so much about nutrition. And who is giving this information? Typically influencers. Not everyone, not anyone of credibility or with any kind of training. Now, there are Instagram and TikTok accounts that people can follow that are from dietitians or do take a more neutral approach with food, but there are so many things. Like, for example, the pH balance of water. That's a whole nother thing that had been marketed on TikTok and Instagram, and that has been going on for the past 10 years or so, I think. But your body balances its own pH. If it didn't, you'd be in a lot of trouble, called metabolic acidosis and metabolic alkalosis. Like, it's not what happens to your body. Just like toxins, like people saying, this is a toxin for me to eat this. Your body naturally is going to detox itself, or otherwise you're going to be on dialysis. That's the function of your body. So, anyway, my tone, I think I'm getting a little ramped up here, but, I'll stop there. But the dietitian also explores movement with each patient. So what does that look like, your relationship with exercise? Like I said, some folks have that component. Some folks don't. But at the end of the day, like movement in general can help mental health. And so what does that look like, or what can that look like for each individual? And then to explore what a healthy body weight range means for everyone. And that is somewhat of a loaded topic, because weight ranges can fluctuate, especially with kids. They should fluctuate. So a lot of times I'll hear parents saying, you know what, she's supposed to be this at this weight at age 15, and she's 17 right now, and they're expecting to maintain the same body weight, which actually isn't appropriate growth. Healthy body weight ranges are really taken per weight history, per lifestyle, per history of eating disorder behaviors. Like Sam was saying, the dieting effects, those can affect someone's metabolism long term, truly. And what does that look like? And also another piece of this as well is that optimal functioning for someone. And a lot of times kiddos, I do see, like, if someone's weight range is supposed to be a little bit higher, but we don't have it there, and they're currently maintaining their health range, but not totally with optimal functioning, like they may still have a lot of food noise or food thoughts. Actually, having a higher healthy weight range can help functioning in general and rational thinking. So we determine it by that as well. It is an estimated guess, professional guess. We are not the weight police. And with the weight, there is something called set point theory, like Sam was talking about, in regards to where your body weight naturally stabilizes in your lifetime, a span of, 20 pounds, for example, without dieting, without manipulation of your body weight. So your body really wants to survive in its most optimal way. And how do we get someone there? Now, the only nuance to that too is if someone comes in when they're 60 years old and they've been chronically dieting their life and restricting and gaining and weight cycling, that really will be hard. Their weight set point may be higher than what it would have been if cycling or dieting had not happened. And what I mean by weight cycling is up and down and up and down and up and down. Your body doesn't love that. We call in this world nutrition therapy, nutrition counseling. I am not a therapist. I draw the hard line in therapy. And so that's where Sam's role comes into play. And so there is a fine balance between all of us working together. It is a beautiful art when it happens successfully. So nutrition therapy involves weight stabilization, nutritional adequacy, So to get more into the lab, I don't know if there's any medical providers on the call right now. So this could mean absolutely nothing to you, but I'll go ahead and say it. We look for CBC, lipid panels, electrolytes, iron, in lab work, and we manage refeeding symptoms. So something that you will see commonly is refeeding syndrome, and that can be life-threatening. Someone who's at risk for refeeding syndrome needs to be in higher level of care, inpatient, but that is not nearly as common as refeeding symptoms. And what I mean by refeeding symptoms is like GI distress, feeling really fatigued, and introducing food again. Normalizing eating patterns with structure, meal planning, providing nutrition education, like I had said, and something that I had not mentioned before, nutrition experientials. So a lot of times for our FID kiddos, we'll do food fear exposures when that's appropriate. For people with restrictive eating disorders or binge eating disorder, it will involve like maybe a fear food or a food that they had binged on, which can be a fear food. And then we also do experientials at grocery stores and at restaurants, and basic food prep and cooking skills, especially in higher level of care. Intuitive eating, I'm going to kind of roast through these so Sam has time. Intuitive eating involves 10 principles, and basically the gist of it is that it is a methodology of helping guide our patients to trust themselves again outside of the eating disorder, physiologically and psychologically around their relationship with food. So really these steps are to engage in trust and building trust that we had when we were 1 year old, with eating or not. And my son for 6 years old, right, who hadn't had any environmental challenges with food availability, but he'll say no to a cookie, when he's not hungry for it. Lots of adults will be like, oh my gosh, should I eat that cookie? No, that's not that complicated for someone who has trust with themselves. And then health at every size is loving our body regardless of the size, or being content with our body regardless of shape or size. We understand how dieting culture increases body dysfunction and eating disorders. So the problem is not you, the problem is society. Helping challenge weight stigma, and moving and eating to enhance your life, not punishment. What can food do for you versus what it doesn't do for you? All bodies deserve to be nourished. You can be malnourished in a larger body. Trusting your body to tell you what it needs and not using BMI as a standard of health. Socioeconomic status, psychological health, occupational health is a part of health at every size, and what actually affects health versus just weight, shape, food, and exercise. Take it away, Sam.
Awesome. Now from the therapist perspective, it is really important, like we talked about earlier, to build a team that is well-rounded. Therapists like myself don't function without dietitians like Melissa, to build up a team to really work with someone to build a team for them to get to a recovered life, but it's also engaging the entire system. We know that eating disorders don't occur in isolation. We need to engage more than just the individual who's struggling in order to fully help them. So some things to establish with your team and with the individual who's struggling is agreeing to attend all sessions or groups. What is the level of care that they're in? And what are you expecting from them in this process? Making sure that we have signed releases of information for all family members and all team members, so that we can all communicate, make sure that the eating disorder isn't splitting people from one to another. It is very crafty because it wants to make sure that it stays around, it serves a function. So the more that we're communicating within the family, within the providers, we're able to kind of reduce that. There's less secrets when we're all communicating. We're agreeing to gain or maintain weight within healthy ranges is determined by the team, and making sure everyone on the team and within the family are agreeable to that. What is the level that we need to abstain from purging or any self-injurious behavior? What is the parameters about participation in self-care, extracurricular activities, sports and movement, making sure that we're aligning that with the meal plan expectations and we're not kind of jeopardizing that, especially in lower levels of care. Making sure we're attending all weights and medical evaluations, whether that's weekly, bi-weekly, to continue monitoring all levels. Again, like we've said many times, we can't just look at someone and know that they're healthy or not healthy. We need some of those other lab values or weight values to make sure that things are working the way that they should be. And what are the expectations? What parameters are you guys setting for someone who may be starting at a lower level of care, but what would you see that would then require a higher level of care? And especially as we're talking about teens and children who are struggling with an eating disorder, we need to engage in family therapy. The family is going to be that key component to help support change so that we're helping shift the entire system for that recovered life. So a big thing is validation. I love DBT. This is a huge component of DBT as well, but something I think as providers we should learn, but also for family members to learn. This will help reduce a lot of those power dynamics that we can engage into with the eating disorder. So validation is really communicating to our loved ones that their feelings, thoughts, and actions make sense and are understandable in a given situation. But just because we're validating does not necessarily mean we agree with whatever they're communicating or how they've chosen to communicate that. And we're working to, in validating, we're improving relationships. It will de-escalate conflict and intense emotions because you feel seen when you're validated. And so it makes it a lot easier for us to move forward, and it kind of brings down our own emotions when we feel like, okay, this person is listening. They understand me. We're not in a judgmental space because they're validating whatever may be going on, and it can ideally avoid a big conflict. So some important things for validation is we want to validate the valid, but not the invalid. And this can feel very complex when how someone is communicating their emotions may not be appropriate, but we understand why they're feeling. So someone who's struggling at the table and is feeling very anxious and upset may throw their plate or storm away from the table. And we can say, I understand how you're feeling. I know this is scary. I know you're really angry right now. And throwing your food, storming away like that, slamming a door, that is not appropriate. So we're validating the feeling without necessarily validating the behavior. Eye contact is super important here as well. We want to make sure we're communicating to them that we're listening, we're not on our phone, we're not distracted. And you can look for words or behaviors that describe that feeling as well. It helps show tolerance that we're able to sit with that loved one when they're experiencing those intense emotions, that they're not alone, that we are there for them because this journey is going to be really difficult. We're going to help respond in a way that shows we're taking them seriously with or without our words. And we also need to validate ourselves, especially loved ones who are struggling with someone who has an eating disorder. It is really hard for you as well, along with your loved one. But as we're looking at that person who is struggling to get to a recovered life, remember, as we've taken away their eating disorder, we've taken their quickest, easiest, most effective coping skill. And so we're going to see an increase in emotions. We're nourishing their brain again. And so we're going to see that influx. It may feel like things are getting worse before they get better, but it's just because we're not dampening the emotions that they have been experiencing. They just weren't letting out. So it's super normal. Just continue validating it, but also validating yourselves that this process is really difficult. Another big component, I think I got this question earlier, is making sure that we're creating a trauma-informed environment. Trauma is a huge co-occurring diagnosis with eating disorders, especially at higher levels of care. And so a trauma-informed care is a strength-based framework that's grounded in the understanding of and responsiveness to the impact of trauma that emphasizes physical, psychological, and emotional safety for both us as providers and the survivors. And it creates an opportunity for survivors to rebuild a sense of control and empowerment. So through this, we've created systems and spaces that allow our clients to feel safe to talk through some really difficult things. And trauma and eating disorders are so interconnected. The eating disorder can serve as a way to not feel the trauma symptoms. And so they serve one another. And so it's really important if there is some trauma history or we suspect there might be a traumatic event, that we're addressing both at the same time. So a way to do that is using cognitive processing therapy. And as the clinicians on this call, there's this workbook. Here's a little clip of the front of the cover of it. And it is a very simple training. As was mentioned earlier, I'm also EMDR trained in trauma, but CPT does not cost you $2,000. With ongoing consultation, you just need the manual to do it. And this is something I'll explain our data in a little bit, but at higher levels of care, we can currently treat trauma and eating disorders at the same time, which is a newer thing. Historically, we've treated trauma or the eating disorder, but not both at the same time, and it almost becomes a whack-a-mole. So in CPT, it is a 12-session protocol with practice assignments in between. And so the goal is not to rehash every aspect of the trauma, but to recover through a combination. What occurred and how do we have an appropriate belief about the trauma that is not grossly impacting our day-to-day life? So there's different phases of starting with assessing all of those safety concerns, going into education about trauma, what it means. And true PTSD, if you have that official diagnosis, is someone who experienced a near-death experience or sexual assault or witnessed either one of those things. To me, a trauma is anything that we experience that our brain just isn't able to process and fit neatly in our little box that our brain likes to put things in and put it onto long-term memory. So the skills of this theory can be really helpful for anybody. We look in the areas of safety, power and control, intimacy, trust, and esteem, which if you look at all those words, we all struggle in all 5 of those areas. So these themes can be really helpful whether we have an official PTSD diagnosis or not. And so the idea behind this is that a client writes their impact statement of how their traumatic event impacted themselves, their view of themselves, others in the world. And through Socratic questioning, by the end of the 12 sessions, they're able to create a new impact statement that's hopefully more accommodating to what is able to, how they're able to see that traumatic event through a different lens without it dominating their entire life. So within our data at Montanito, we do collect data on our clients as a part of a research study. It is kept completely anonymous. It's just tracking through, are the things that we're doing effective for our clients, and kind of just gathering data for the field. As we talked about earlier, there's not a ton of data, especially on anything beyond anorexia or bulimia. So we want to continue helping move forward the eating disorder community. And for our adults who enter residential treatment, 45% of them have a PTSD diagnosis, which is a really high number of the clients coming in. That's nearly half of them have meet criteria for a full PTSD diagnosis. That's not including those clients who have the quote little t trauma that's still impacting them, but may not meet that DSM criteria. And so you can see on the right here is our overall improvement of our clients. From the checkered line is our clients who come in with a PTSD diagnosis, and this scale is out of 5. So they're not only experiencing PTSD symptoms, but very significant eating disorder symptoms as well. And all of them make improvements and sustain those improvements 6 months post-discharge. But this just shows how important it is as we're assessing level of care, what is a good fit for our clients, to make sure that we're able to treat more diagnoses than just the eating disorder, because it's not occurring in that isolation. Something else to consider is sexual and gender minorities in eating disorder treatment as well. They not only have higher rates of eating disorders, but higher rates of admitting to higher levels of care with PTSD as well. So for our adults in residential treatment, 24% of them identify in the LGBTQ plus community, and they admitted with higher rates on the score of the PCL-5, which is a PTSD assessment scale, compared to their cisgender counterparts. So it's really important also as you're assessing those levels of care, what is a level of care that makes your client feel safe from a gender-informed perspective as well. And lastly, for adolescents, 38% of adolescents who admitted to our residential program had met criteria for a PTSD diagnosis, and 75% of them endorsed at least one type of childhood trauma. So those clients had significantly higher scores again on eating disorder and PTSD scales. So it's really important that I appreciate all of you guys that are here today for the importance of talking about these things to make sure that we're helping our clients who experience eating disorders and trauma, and the early intervention and supporting them will help them get to a place to reduce those overall scores, and they are able to discharge from higher levels of care at that same level of clients who don't have PTSD with their eating disorder as well. So I think just so we don't have to share a screen again in a little bit, here are some resources before we go into questions in the panel. The FEAST program is a really great organization that supports family members, loved ones, siblings of loved ones who have eating disorders, all free resources with ongoing support groups. It is founded by a mom who had a child with an eating disorder as well. The National Eating Disorder Association, or NEDA, is a great resource along with the National Association of Anorexia Nervosa and Associated Eating Disorders, or ANAD. We have to have all of these acronyms, or that would just be a mouthful to say all of these things all the time. And here's some other resources for you guys to just, if you want to continue learning about eating disorders, that publish research and those sorts of things that are accessible to you just by going on their website.
Thank you all so much. This has been so helpful. Really wonderful information. We have a few questions that have popped up. So I'd like to review those before we move forward with our panel. One of the questions in the chat has to do specifically with the DFW Metroplex. The question is, are you aware of cooking classes that teach people/teens how to cook healthy meals?
There are a few places for teenagers that are general cooking classes. There's not for, well, I take that back. There are certain therapy groups that hold cooking groups for adults and adolescents, depending upon their schedule. So that would be something that we can connect you with. Those are come and go. There are Flour Power, FLOUR Power cooking class setup, and that's pretty fun. Like they have like Harry Potter themed things. Like it's not just for little ones. It can be for teens, just from a general standpoint. And there's really very minimal, from what I have researched and participated with with my own child, very minimal dieting talk, none at all, really. I would smash that down pretty fast. And then there's also Kids Academy. Oh goodness. Young Chefs Academy, in the DFW area as well. So those are just general. There are therapy practices that do cooking classes from a eating disorder perspective. People do get cooking classes and IOPs programs and PHP and RES. And then also individual providers can do cooking experientials with particular patients as well.
We have a question from the Q&A. It seems like it may be hard to distinguish between types. Do treatment options vary a lot based off of type? I don't exactly know what that means, but.
I think I know where the question is going, so please correct me if this is your question and not what you wanted me or us to answer. It is a very nuanced way of diagnosing, and it's not necessarily as important um, for some of those bigger groups, whether it's anorexia, bulimia, binge eating, ARFID, especially if you're needing that higher level of care, we diagnose just for insurance purposes more than anything. But in those levels of care, even in outpatient, we're more treating the behavior. So a behavior is a behavior is a behavior, regardless of what box you want to fit it into. So that's the bigger thing. Some of those more nuanced diagnoses, if it's pica or there's the co-occurring pieces of maybe some neurodivergence, that would be where treatment options, especially at higher levels of care, may be different based on the specific presentation. But there's not many programs that are only for anorexia or only for binge eating disorder. So hopefully that answers that question.
We will hope so. Okay. Any advice for a middle school counselor who has groups of students not eating lunch because they are on a diet?
Oh man.
Oh man. I can just see this happening right now. I'm sorry. Goodness, it's really like, why? Like asking the question of why are we on a diet? Is it because all our friends are? And like the side effects of dieting really actually don't help you. And as a teenager, you still got to grow. So introducing those things of like dieting actually isn't a good thing, which a lot of people think it is. They think that's what they should be doing. But in reality, that actually can be very harmful. And per Health at Every Size research, you can actually, so dieting, and it says this in intuitive eating as well, dieting is one of the lead indicators of future weight gain. That doesn't make any sense when people dieting. It does make sense for our perspective because we know the science behind it, but it actually causes weight gain in the future. Anyway, I would say highlight why dieting actually isn't a good thing, kids. So.
Beautifully
Favorite
said.
thoughts? Yeah. Okay. I'll come back to this other comment, but it sounds like family can play a large role in eating disorders. How do you get the parents on board for the recovery plan? How do you get buy-in?
I'll speak from the therapist perspective, and if you want to speak to the RD perspective, that can be the biggest support or the biggest barrier when it comes to someone's recovery. We do lots of education on, similar to what Melissa was just talking about, which may be helpful in that middle school arena, helping parents as well. We've all grown up in the culture of what our body size should be, what we think, and it's helping parents understand that if we're focused on the weight, if we're only focused on that number, then we're making that okay for our kiddo to do as well. So how do we help them focus on just overall health, and helping them see there are bigger struggles than just the number on the scale, and getting them involved too. As great as we are as practitioners, I'm not going to be with you forever. So I need your involvement because you're the one who will be with your kiddo long term. So I need your support in being able to, I can be a miracle worker. I'm not that great at my job. So we're not going to get to a place where I'm fully curing whatever is happening, and fixing the whole family system.
Yeah, I would say there's an excellent resource on NADA. It's called a Parent Toolkit, and you can download it. And anybody looking for it, you can always email me about it. But it does explain thoroughly some of those myths that we talked about, and then the insurance process with eating disorder treatment. And there's also coaching toolkit. There even may be a counselor's toolkit for eating disorders. So it kind of gives some brief information on what this actually looks like and the need for treatment, because the eating disorder just won't go away. And so at the end of the day, like are we going to help this process, help your child right now, or are we going to wait till they're off in college when they don't have much as a support system? Again, every family's different. Some kids do better in college. But it's like how do we want to move forward with helping your kiddo? So this doesn't happen, or this is reduced risk factor in developing again in the future.
I don't see any other additional questions at this time. I'd see a comment that Children's Health used to have a program called Get Up and Go that offered cooking classes for families with kids of all ages. So unsure if that is still a program that's up and running. Yep, that is all the questions I see at this time. So without further ado, I will let you all introduce our panelists.
Okay, so we have Miss Jackie and Kristen on video, and I have had the utmost pleasure in working with their family for a handful of years now, and it was truly an honor to ask them for Kristen to be recorded and for Jackie to pop on for our panel. I think they're going to be a great resource, like a real life experience to you all in what this looks like and creating some hope for those who are struggling with eating disorders, because we have a positive story. I just kind of want to do a little bit more of a formal introduction. So Kristen wasn't able to attend today. So we pre-recorded an interview with her to share, and we will share that first and then have some time to speak directly with Kristen's mother, Jackie. So please feel free to share questions with Jackie or for Jackie in the Q&A section. And Kristen agreed to come and share her story with us. She started recovery almost 4 years ago. Seems like just yesterday, but not at the same time. And she is when she was 14. So she is currently a student at the University of North Texas studying biology, and she enjoys thrifting and spending time with friends and family instead of counting calories, right? And Kristen's mother, Jackie, will join us live to share her experience. And we are so thankful to have you on board and sharing your experience and sharing your story. It is not an easy topic to talk about, but what an amazing journey Kristen and Jackie have had in their recovery, working together, and Kristen's work too. All right, so I think it's time to bring up the video of Kristen.
For those that are joining us, this is Kristen Ramirez, and she wanted to share her story with us. And so we'll just dive in. So Kristen, can you just start and tell us a little bit about your experience and when you realized that you needed help?
So I suffered from an eating disorder for a couple years before I got help. But even when I did, like at the time, I didn't realize or like believe that I needed help. And I kind of like, I thought the way that I was surviving and the way I was like treating myself was normal, which I think that's a fairly common experience. Some people like know, but I did not know. And then I had forgotten anything about like my life without it. So it was my normal. It was not normal. But so I didn't feel like there was anything to get help for. But I started recovery when my family and my coach and my like close friends were like expressing a lot of concern. And like, even though I hated it at first for a while, I think I found my original motivation to stop concerning the people around me. And so, yeah, but in short, I didn't realize that I needed help at first, but then like the people around me were able to get me the help that I needed.
What did they do? How did they communicate to you that they were concerned?
My my coach first to my parents. I was in gymnastics at the time,
Okay.
and my and she was like, Kristen's like looking a little weak, like she's not really acting like herself. And then my parents came to me and they were like, we're concerned about you. We want to bring you to the doctor. And so that was the original story.
Mm-hmm. And then what happened after that?
After my parents brought me to the doctor, my doctor recommended me to an eating disorder hospital. And then I went there, still in denial about having an eating disorder. And then I went there, I met like some of my providers. They were good. And then yeah, from then on, I was in recovery. This was almost 4 years ago.
Okay. Yeah, so it sounds like there's been definitely some time since then. At what point, you mentioned that you were kind of in denial at the beginning. Like, at what point did you realize that there was more serious things going on, and like what clued you into that?
It was while I was in the hospital. I had gotten there and my dietitian and therapist, like, I think they realized that I didn't fully comprehend that I had an eating disorder. And so they like really tried to push me into, that there's something wrong. Like, you cannot go like through this all and not realize that there's something wrong. So it was a lot of the people around me telling me at first, they're like, you need to treat this seriously, stuff like that. And then I eventually started believing them.
Okay. Can you share a little bit about what was hard for you?
I think there were many difficult experiences. And then, but just recovery in general is like the hardest thing that I've ever done. But relating to getting help, it was hard to rearrange my entire life for something that I didn't even think I needed help for. Because I mean, that's what you do when you go into recovery. You can't continue some of the things that you were doing. But eating disorders are such like powerful things. Like they can convince you of things that are entirely untrue. Um, and so, yeah, I think just there were a lot of things. Partially,
Yeah.
like the first part relates to a lot of the people around me, and it was hard to see them like look at me and be worried. And I didn't want to burden them. I didn't want them to like worry anymore. So, yeah.
Mhm. Yeah, so it sounds like in the beginning, the motivation to get help was really because of the concern of others. So it was like kind of external to you. At what point did that turn for you? And then also like what internal strengths that did you have inside that, it sounds like it sounds like changing your whole life, which I also have some questions about that. Like some of your habits had to shift, but like um what helps support you, through that internally?
I think one of the first exercises that I did while I was in the hospital with my therapist was to list out the things that I valued. And I still remember that session like to this day because I kept that in my mind and kept the things that I valued in my mind for so long. I still do. And whenever I was thinking about like, oh, maybe this isn't worth it, I'd think about like my family and how I wanted to go back and see my family because I valued relationships. And at the time, I valued my health and I still do. And I knew that what I was doing wasn't getting me anywhere healthy. But, and so I think I had a lot of strengths in what I valued and what I wanted from life.
That's a really helpful example. That it sounds like help, connecting and raising awareness to what was important to you helped you really align new habits and also align with why you were doing what you were doing.
Oh, very. Yeah.
Okay. And then what you said you had to change a lot of habits through recovery. Can you walk through what some of those changes look like?
So at first it was I changed my time to spend more time making and eating meals and like being mindful during them. And then it went to changing my school habits. Like I didn't change schools, but I changed I was very school centered at first, and that was all I would spend my time on because I didn't feel like I could do anything else. Like that was what I wanted to focus on and what I wanted to control, other than food and all that. But so I had to change my school habits. There's when I went back to school, it was there's my grades had dropped at that point, but I honestly would do that all over again because but at the time it felt like the end of the world. But I would do it all over again because changing those things and changing like the schoolwork that I was doing and I had to quit gymnastics. My treatment team made me do that. And I had done gymnastics for 10 years. So I think quite a few things, some habits that I had during that. I built more healthy relationships through it though.
Yeah, yeah. Um, what do you feel like people don't really understand about eating disorders? Or even maybe what you didn't understand that you learned?
Um, I think people in general think of it as more of a physical illness than a mental illness. And in my experience, and I'm pretty sure every experience of everyone that I've ever met with an eating disorder, it is there's so much of a mental aspect to it. And a lot of people still hold on to the belief that it's all surrounded around someone's body or someone's weight. And although it can start from that, it's so much more than that. And I think my treatment team understood, but a lot of general like practitioners think that you can recover from an eating disorder by just like fixing their weight, and that is not true. It
Yeah.
requires a lot of therapy and a lot of mental work along with physical work, but it's it's very much mental. And I didn't fully understand that at the time that I started recovery, but it was it was very obvious that that was affecting more than just my physical health.
Yeah. When did that click for you?
Um,
Or was there anything specific that started to help make it click for you?
I think once I technically, according to my doctors, had weight restored, I still didn't feel better. I felt like the same. I was in the same mindset basically. I think that's another thing people don't understand is that there's there can be people that like think like you look at them and you look at their body and you think they're healthy, but they're not. Like they can be just as sick as the next person. Um and yeah, I think it hit me when my doctor was saying that I was medically stable, and I didn't feel like it.
Okay. And then, like, what was the toughest mental component that you had to overcome?
Um I think there were there were so many things that probably wanting control over things. I wanted that was a large part of my eating disorder, was that I wanted control over something, and I focused on food and my body instead of, normal things. But I just, like, I wanted control over something, and I had to let that go. I had to go up and, like, well, not give up, but I had to give up that kind of mindset of everything needs to be perfect, everything needs to go to plan. I think by now I'm very yeah, plan it, but also like go with the flow. Like it's like
Yeah.
it's not going to be the end of the world if something doesn't go exactly how you planned it in your mind. So letting go of that sense of control.
Yeah. I think that's so important what you just said. And I'm so curious, like, because saying I want to let it go, like let go of control, and doing it there's there's a huge gap between those two. So like, what supported you? And I'm thinking, people that are going to be listening to this are people that are helping, the helpers that are helping people. So hearing from you, like what was helpful, especially as you reflect back, to really start to let go.
I had a lot of controlled exposures, like exposures to things that I wasn't comfortable with at the time, but my dietitian would sit there with me as I had like a new food that was against my kind of like eating disorder rules. And then as like she exposed me to that, then I was able to slowly do it on my own. And then like my therapist would expose me to, I don't know, some random thing that I would say I had anxiety about. And then but I think a lot of it was the controlled exposures of things that I didn't feel like I could control at the time. There's exposure therapy is real and real helpful.
And what things like on social media impacted you, either before you were aware that you had an eating disorder, or after?
Before it was the the lights just turned off. It was the comparison. I mean, I think like everyone that goes onto social media has compared themselves or their life to someone else. Like that was at first, like when I first got on social media. And then but then after, when I was in recovery and I was like opening up to just like my close friend's story on Instagram, then I got a lot of support from people. And even though like the same app that I was comparing myself to, I had changed what I was looking at and what I was doing on there and looking for on there, that it changed from a comparative thing to a place that I could find support.
And how did you change that?
I had to actively look for it. I looked for like some like people that I felt like would understand what I was going through. And so just like recovery accounts that I didn't feel like were sketchy. There's I tried to avoid like going back to accounts that I compared myself to before, or compared my life to, things that I felt like were severely edited or fake. That was, I think I had to search for it at first, and now it's just kind of my algorithm brings me mostly positive things.
Yeah. So it sounds like you find that it's supportive to you now compared
Yeah.
to what it was and what you were looking at before. Now, you had mentioned in the beginning that you had to give up, it sounds like, a lot of things. that you were really identified with, like gymnastics and even some, it's probably definitely your routines and things like that changed. How did going back to school and kind of transitioning into your environment, what did that look like? And how did you educate like your friends, or did they change? And what other factors did you bring in to support you?
I got First, I got accommodations through my school. So my teachers knew and they were able to support me through assignments and stuff. But as far as my friends, I talked to most of the people that I did before I went to treatment. Just like just the ones that I felt like were good, you know. I At that point I was like, I don't really mind if I lose a couple people just because I want healthier friends. But I talked to some of the people. Obviously, I had changed, so some of the people didn't really fit me anymore. So I kind of faded out with a couple of people. I'm a pretty social person. I like talking to people, so I made friends pretty easily. My friends were willing to learn. They were good. Especially my close friends, like at the time and now, they're they're willing to learn. They're very curious too, because a lot
Yeah.
of my friends have not experienced like an eating disorder, so they're curious.
Yeah. Well, and it helps that you're so open. Seems like you're really comfortable sharing your story. Yeah. Is there before we wrap up, is there anything that you feel like is important for people to know, that maybe we didn't get to touch on?
Um, I don't know. Oh, there's I think a point that I like to make with a lot of people that I talk to, especially those that have eating disorders or um like have friends that suffer with eating disorders, is that I hear a lot that like, oh, recovery takes time. And I completely agree with it. I do think it takes a lot of time, okay? But I think a lot, like the part that's not added is that it takes a lot of effort. It takes time, but in that time you have to put a lot into it. There's so you can't just
Yeah.
it's not something that magically happens. It's not something that um a doctor like weight restores you and then leaves you alone and then you get fairy dust and you're recovered. Like I don't know. I feel like that's a lot of things that people don't understand when they say recovery takes time, is that it takes time and effort.
Yeah. It sounds like you're saying like you have to stay motivated and want to do the work in
Yeah.
order to really see changes.
Mm-hmm.
Yeah. Was there any point that you wanted to give up and not do that work and put in the effort?
Yeah. I think there's a point for most people that are in recovery that they do not want to do it. It's a very hard thing to go through. So people like it's very easy to lose motivation, especially when an eating disorder is able to convince you of things that like, oh, this isn't worth it. You should just go back to how you are. Like that's like it's a very powerful voice that you just you have to fight through. You have to reach out, tell people what you're going through. Um, so overall, yes, there were times, but I'm here, so I didn't give up.
Well, thank you so much, Mandy, for leading that interview, and to Kristen for sharing her story. We are grateful for the opportunity to learn and to ask questions, and we're honored to be joined now by Jackie, Kristen's mom, who is here to answer some questions for us and to help just shine some light on a very challenging subject matter. So thank you so much, Jackie, for being here. We're grateful for your time.
Thank you so much for having me. I'm very excited to be here and a little nervous too.
Oh, we're all amongst friends here, so
Yeah.
Feel free, folks who are on our call today, to add any questions that you might have for Jackie in the chat as we move along, and we will do our best to answer those. I'm going to start with just a few questions, Jackie, if that's okay with you.
Absolutely.
Can you share a little bit about when you noticed or became aware that Kristen might need help?
Yes. First of all, hindsight is 2020. So, being almost 4 years out and then reflecting back on the things that I noticed along the way, I have to admit that those things that I noticed, I did not attribute to an eating disorder at the time. I attributed those things to a 14-year-old teenager. For example, baggy clothes, to hide her body. I attributed that to, it must be like the style at the time, because I remember that I went through a baggy clothes phase, and I did not have an eating disorder as a child. Let's or as a teenager, let's throw that out there. But I went through a baggy clothes phase, so like normal teenager. Same thing with when she was grumpy. Um, Normal grouchy teenager maybe. And she took up cooking uh, a lot, or at least some anorexic individuals will take up cooking, but they actually don't eat what they cook, which I don't know if you covered that earlier, because I've not been here the whole time. But she took up cooking and feeding us, and I did not, what I noticed was that she was cooking. What I did not notice is that she was not eating what she was cooking. She was, so it was kind of a trick, honestly, a tricky little thing. One thing that I remember thinking about was her gymnastics competition uniform at the beginning of the competition season. What they would do is they would wear the competition uniform 2 years in a row, just because they're expensive. And she could barely get the thing on at the beginning of the competition season. And I was like, we really, I'll order you a bigger one. And she's like, no, no, I'll get into it. I'll get into it. And she's stretching. And by the time she went into the hospital, it was baggy on her. And that I didn't notice that until after she was in the hospital, honestly. That was like one of those hindsight things. Those are some of kind of the the main clues, but I did not see her as sick until well, we might get to that story. But anyway, the point is that all those things did not indicate to me that she was sick, that she had anorexia.
Was there a moment where you did have that realization of
Oh yeah.
need
Yeah.
to?
Her dad was taking her to gymnastics and raised a concern about her weight and the way she looked. And she started crying, and they, kind of had a little fight. She came home, and my husband had to work that evening, so he dropped her off, and she was crying, and I was able to she was crying hard. I mean, this is like, and this is still at the time where she, just in this video, said that she did not realize that there was a problem. Yet she was standing in the living room and she was sobbing, and I was able to pick her up like when she was younger. I physically picked her up in my arms, sat down in a chair with her, rocked her, and started talking to her about what Dad had brought up, and just some feelings. And then she told me that she was afraid of how much she weighed. And I said, and I knew,
Okay.
sorry, I knew at that moment that she had that she had anorexia, and it was just a matter of getting the diagnosis. I made her weigh herself, and she didn't want me to come with her, so she went into the bathroom, got on the scale, and came and screamed. She was 84 pounds. We went to the doctor the next day. The doctor was like, she probably doesn't have anorexia, but here's some resources. We called the Eating Recovery Center's hotline that night, and they spent some time talking to her, and uh and then they spent some time talking to us, and we were on the waiting list immediately for the first opening, which we happened to luck out. It was within a couple of weeks, and she was in the hospital.
Can you, speaking
But I
of
knew.
navigating those systems, how was that process of navigating? Where do we go? How do we begin to find help? Like, what are the resources? What was that process like?
Um, the Eating Recovery Center is near us, that she went to, but people come from all over the world to get treatment there. And so actually it was like, because it was a top-notch facility, it was navigating that was relatively easy because we knew that that was where we wanted her to be placed. What was not easy is that the waiting list was so long that it was going to be probably 4 to 6 months before they could put her in treatment. And I didn't think she honestly would survive 4 to 6 months. And so that was terrifying, honestly. Um, that's why we were like, we will drop everything. We will bring middle of the night, whatever. If there is any opening for any reason, we will have her there within an hour. And we did. And it was complete luck, honestly, that someone from another country was unable to take the spot that they had waited a long time for. And we were packing things frantically and had her in the next day. They weren't going to take her that night, but they gave us like 24 hours to get her there. So that was that navigating care, not just to get her into inpatient, hospitalization, but even, the different steps down that they go through as they go through recovery. For us, that was not particularly difficult. But we also have factors working for us. My husband has a very flexible job. I have a very flexible job, and we are socioeconomically very comfortable. And so we could afford the care that she needed. And honestly, that paved a smooth path in terms of navigating the system of care.
What support did you get throughout this process? And was there something in particular that helped you?
Oh, there was so much therapy, not just for Kristen, but for us too. ERC had about, I would say, 10 hours a week of between parent education, parent therapy, family therapy, that were available to us. They were not required. But my husband and I both attended every single session of every parent education opportunity that we had available to us, so that we could learn how this happened and how we could contribute to fixing it. Ultimately it was Kristen that needed to do the hard work, but it's a system, and she needed a strong system in order to be successful. We knew that, and so we dove right into it. Another really important piece of support was, for me in particular, was my workplace. Was they all of I was open about it from the get-go, and all of my manager, my vice president, it surrounded me with love and support, and they gave me flexible time off. I did not have to take PTO to attend the 10 hours a week of therapies. They lightened my workload. They offered FMLA leave if I felt like I couldn't work. I did not take that because we might be a little bit workaholic, my husband and me. And, it's very hard, even though they told us if you have an opportunity to take time off for yourself, take it, because when Kristen comes home, it's going to be hard. So rest now because it's going to be a tough thing. Of course, I took advantage of all of the things I could take advantage of with my work without taking the FMLA, and I should have taken the FMLA. Now that I know that. But yeah, those were some of the
Those moments of support. throughout the-
yes.
Is there anything that the treatment team did that you found helpful, or something that you wish they would have done differently, perhaps?
Oh gosh, the treatment team was for us fantastic. They educated us. Uh, I mean, because we participated in so many hours of therapy and education a week, they educated us on. They never said, you did this wrong, but but they told us about, educated us about things that we might have inadvertently done, or like the family dynamics that might have contributed to the kind of the pressure that Kristen felt, or the perfectionism. I would say that my husband and I are both pretty perfectionistic ourselves, and she learned that from us. And to keep in mind that when we were talking to Kristen as she was in early recovery, that we were talking a lot to a sick individual, and the things that were coming out of her mouth were that might have been very angry or very difficult to hear, were coming from a place of a person whose best grand plan of how to live her life at that time landed her in eating disorder inpatient treatment. So to keep that in mind, and that the longer she was in recovery and the more progress she made, the more that would fade away, and the stronger the real, what I would call the real Kristen would become, and the easier it would become over time.
Hmm. I get a follow-up question. I think that as you're talking, I'm like, oh wow, your story is so powerful. Thank you for sharing. What does it look like to support Kristen in her recovery journey now?
Oh my gosh, it is easy, honestly. She is so, I mean, you saw the video. She is so strong. She is so smart, and she did, I mean, they told us in parent education um that her brain was probably physically affected, and that was reflected in the cloudy thinking that we saw, and the just the struggles that she had academically um after I mean, once we realized she was actually really sick, and when she re-entered school, it was like she couldn't think clearly the way that she thought before. And they told us it would take about 3 to 5 years probably for her brain to heal, if it would ever heal. It has healed. She is I can't tell you how amazing she is and how easy it is to support her. She asks for support when she needs it. It feels like she hardly ever needs it, but she's fun to be around. And when we spend time together, um, I think, I mean, now it just feels very natural, but I do think that it is still part of her recovery, to to share time with her and to share experiences with her and share stories about when it was not so easy with her. We did that recently. We had a conversation about how she talked about she didn't even realize that she was sick probably until she got the feeding tube in inpatient. And even then she was a little like, this is kind of overkill. And I'm going, and she had a feeding tube, you know. So I knew before and she's like, Mom, I can't believe you knew before I did. And I'm like, well, maybe it's just because, I all of a sudden I could see where it took her a little bit longer to see. But gosh, it's so
Comment
easy
in
to support, so easy to support her now.
Wonderful. We have a comment in the chat that I wanted to read to you. It's not a
Sure.
question from this person. They just want to say that as her mother, you are a champion for the way that you handled the initial conversation and and not only and for further exploring the resources given to you by the doctor, but pursuing those resources to get a second opinion. You and Dad are a fantastic team as parents, and without a doubt, saved her life. So, another comment, Kristen and Jackie are inspirational. Thank you so much for sharing intimately personal stories. Best wishes for continued strength. We are grateful. I do want to open it up, Jackie.
Thank
And if
you.
you have any questions, please continue to put them in the chat. You have a ton of clinicians and providers and practitioners on this call right now. Is there anything else that we didn't talk about that you'd like to share? Any words of wisdom, any gems for us today?
Oh my gosh. I don't know that this is a gem, but for families who are less educated, less connected, less financially stable, if you can step in and help on helping them find resources and helping not just helping them find them, but helping explain how to access those resources and um supporting them as best as you can within their potential limitations. The only way I can't see how she could have gotten better without a system of support, and I can't imagine a family that is um struggling financially or maybe is just not as educated as my husband and I are. So maybe doesn't understand like Kristen explained the mental component, not just okay, your weight restored now, so it's better. I mean, just really getting into some of those nuts and bolts with them that I don't really know how to say kind of what I'm trying to say, but just hand holding. You might have to do a lot more hand holding than you might think you need to. And
Yeah.
that that is so important. It is so very important.
We had a question pop up here.
Sure.
Can you speak about the transition back home and school? What did you do to support her during that process, that transition, and what did the school do to help with that transition?
The transition back home was I mean it was kind of slow. She spent 6 weeks inpatient, and then she spent 6 weeks where she would come home and sleep at night. We'd pick her up at like 7 o'clock at night, drop her off at 7 o'clock in the morning. And then it was about 7 weeks where she was in partial, I think it was no, intensive outpatient is what it was called. And it was, so again, bringing her to the hospital for about 6 hours a day, coming back and picking her up and bringing her home. I mean, this went on for the course of a few months. So the, and each step we were getting more and more education about how to support her. So, implementing those skills that we were learning, as the responsibility for helping her fell more and more and more upon what was happening at home. Now, as far as transitioning back to school, we went to the school and explained that she was going to have maybe missing a lot of school, and they put in place a 504 education plan and put a ton of support where things like where other students might have to do 10 assignments, she might only have to complete 2 successfully in order to, finish the unit, so to speak, or longer testing time, or like if she missed an assignment, she got 2 kind of grace period days or a week of grace period to turn it in still with full credit. I mean, just a lot of accommodations, but there was also we had to be 100% honest and open with the school about, you know, what she was going through in order to put those accommodations in place. And the transition back to school at first was not easy because she was gone a lot and people wanted to know why. And at first she was not wanting to tell people why. And then she, started feeling better and so she was able to feel comfortable opening up, and that made the execution of the 504 easier for her from her perspective. She didn't have to be secretive about it. So yeah, it just kind of gradually got easier and easier for her and for us as well.
Thank you, Jackie. Melissa, and I'll tag you in if you have any additional questions or anything at this point too. And if anyone has any more questions, put them in the chat for us. That we will begin to wrap up here in just a second and get our link for the evaluation. I want to say thank you so much, Jackie. Thank you so much for sharing with us. We're so grateful and so appreciative of your time. Thank you so much.
My pleasure. And if it helps one family, this was nothing. This is de nada. Yeah.
Your advocacy is very much appreciated. Thank you so much. Melissa and Sam, thank you so much for your presentation and for sharing so much with our audience today. We are very grateful. Okay, thank you everyone for joining us today. Also, I'm going to read off my little piece of paper right now, so don't mind me while I do this. Before we end today's wellness workshop, I would like to talk with you for just a moment about our online evaluation. Please take a moment to visit the link on your screen before leaving and complete the evaluation. Can we have someone put that in the chat as well? That would be helpful. So there's the QR code you can scan, but we'll get that in the chat for you too, so you can complete that evaluation. Please make note of the email you used when filling out the evaluation. When you submit your completed evaluation, a CEU certificate will be sent to the email address that you have entered so that you can access it and print it later. We take your feedback very seriously and use it to help plan the topics, speakers, themes, and formats for our future workshops. And that is very true. We read through all of the feedback to plan the future workshops. We will also notify everyone when this recording is available on our website, so you'll be able to go back and access the video and view the workshop. Our next wellness workshop, get your pens, make a note now, is on February 7th of 2025. It is titled Media Use and Access for Youth, Navigating the Good, Bad, and Ugly Sides of the Internet, Social Media, and Gaming. That sounds fascinating. I'll be sure to be there. Thank you so much for your attendance, everyone, today. We look forward to seeing you at our next wellness workshop on February 7th. Feel free to log off after you complete the evaluation. And we will hang around for a little while if anyone has any questions.